design the research protocol, what is the format of the dissertation. So once you have defined your research question, you would definitely go in for a review of literature on the topic where you have selected. And as it must have been told to you by the speakers yesterday, that when you decide on a topic, before deciding on a topic, you read around the topic. And once you have zeroed into your topic, then you read within the topic. And then having read within the topic, you identify the gaps in research which are there in that topic. And based on the gaps in research which are there, you formulate your objectives. Having formulated your aims and objectives, you are ready to select the study design. Now, how do you go about selecting the study design? See, first, you have to decide whether your study involves any intervention or not. Intervention means, would you like the things to happen as they are and just observe them? That is, you would not intervene anyway in the natural history of or the natural process of the disease. So if you are not intervening in the natural process of the disease, then you go in for an observational study. But if you are intervening, let us say you are trying to find out a new methodology or a new technique of treating something, then and you are intervening by introducing some new procedures, then you would go in for an experimental study. Now, if you are not intervening and you decide to go in for an observational study, then you need to see whether you have a comparison group or not. If you have a comparison group, then you go in for an analytical study. And if you do not have a comparison group, then you go in for a descriptive study. Whereas if you have an intervention, then you go in for an experimental study. Now, in an experimental study, you will have to decide whether you can randomly allocate your subjects or not. If random allocation is possible, then you go in for a randomized controlled trial. And if it's not possible, then you go in for a non-randomized controlled trial. Now, I think I should not go into the details of random allocation because the experimental study is beyond the purview of my lecture. So I will stick to observational studies, since I will be covering only descriptive and analytical studies, and the experimental studies will be dealt with in details during the course of the day. Now, this is the same. Did investigator assign exposures? As I said, that means have you intervened? If you have intervened, then you go in for an experimental study. Otherwise, you go in for an observational study. Now, let us talk about the experimental descriptive studies. Now, descriptive studies are basically studying the distribution of the disease or the health-related characteristics with which the disease seems to be associated. Now, here we are talking of the distribution of the disease. That means how is the disease distributed regards time, person, and place. Means who are the people affected? Is there any particular time of a year or the season in which they are affected? Time, person, or place? Or are there people of some region which are more affected than the others? So you describe the distribution. And then you identify the characteristics which the disease seems to be associated. Now, that means if you find that a particular disease is associated with, let us say, a particular risk factor. Now, here we are talking of association. Please mind it, we are not talking of causal. That means a factor may be associated, but may not necessarily be the cause of the disease. The risk factor may be associated with the disease, but it may not be the cause of the disease. So the descriptive studies are only concerned with studying the distribution of the disease and health-related characteristics and identifying the characteristics which the disease seems to be associated. Just a second, sir. I'll
geotag wala.
Yeah, sorry, there was
Yes.
some technical problem.
Okay.
Okay. So in a descriptive studies, the aim is to generate a hypothesis. We are not testing a hypothesis. A descriptive study usually formulates a hypothesis, or that is, it generates a hypothesis rather than testing the hypothesis or determining the relationship between the outcome variable and the specific risk factors. For descriptive studies, please note this, that the descriptive studies do not test a pre-formed hypothesis. We are forming the hypothesis in a descriptive study, and once we have formed an hypothesis, then we proceed to test the hypothesis with the help of analytical studies, which will depend upon the type of study, the case control or a cohort study. This study is done only in one group of subjects, and there is no comparison group. As I had initially told you, if you have a comparison group, then you go in for an analytical study. If you do not have a comparison group, then you go in for a descriptive study. Now, these descriptive studies can be a community-based studies or hospital-based studies. As we proceed, this will become more clear that if you are doing it in a community, say you are trying to find out the prevalence of hypertension in a given community, then you could do it in the community. Or if you are finding out some disease in which the patients have been hospitalized, then you can have a hospital-based descriptive study. Now, the end result of the study is the study just proceeds to describe the mean value, proportion, and distribution in time, person, and place. Now, usually what happens is students come to us, they have carried out a descriptive study, and then they say, sir, we want a statistical analysis to be done. Now, please, this should be very clear that in a descriptive study, you can only find out the mean values, and at most you can find out the 95% confidence intervals, or you can find out proportions. There are no tests of significance which you apply in analyzing a descriptive study. You may try to find out the association between a risk factor and another variable, but ultimately you end up finding out the mean values, the proportions, and distribution in person. Now, these descriptive studies, which try to find out the distribution as respect to person, place, or time, this could be done among populations or among individuals. When we carry out a descriptive study among population, we carry out what is known as correlational studies. Whereas in individuals, we carry out case reports, case series, cross-sectional surveys, and longitudinal surveys. Now, correlational or ecological study. Before I proceed on to the presentation, the transparencies, let me make it clear, or in short, let me tell you what is correlational studies. For example, if we say that as the pollution level increases, as the air pollution level increases, the number of asthma cases will increase. That means we try to find out whether there is a correlation in the increase in the pollution and increase in the incidence of asthma levels. Similarly, we can also decide the correlation between two factors. Here also, we do not intervene. What is happening is the pollution is happening by itself. The asthma, the people are suffering from asthma by virtue of being exposed to the pollution. And what we do is we just observe whether the number of people who are exposed to the pollution are more prone to get asthma or not. So the objective of a correlational or an ecological study is to compare the disease frequencies between different groups during the same period of time or in the same population at different periods of time. Now, in different groups during the same period of time, we may take up 2 villages. Now, let me give you an example. If you have taken up 2 villages and we decide on studying the effect of fluoride. Now, in one village, if the fluorine levels of water are more or they are less, and in the other it is normal, then we compare the incidence of dental caries or fluorosis of one community with the other community. So here we have different groups during the same period of time, or it could be the same population at different period of time. That means if we study one given population of one given village, let's say, then we study this village during, let us say, periods when the air pollution is high and during a period at different period in time. That means at a period when the air pollution is high and compare it with the period when the air pollution is low. So here it is population is same, but we are doing it at a different points in time. So that is the objective of a correlational or ecological studies. Here we are studying the groups and not individuals. As we said, it could be population or it could be individual groups. So here we are studying the groups. That means we are studying the incidence or the prevalence of asthmatic episodes in the group of people. That means what percentage of the people are suffering from asthma, and we are not talking of individual. Or another example would be coronary heart disease and mortality rates in the population group and the per capita cigarette sales in 1960 by state. That means we see that as the per capita cigarette sales increase, the coronary heart disease increases and the mortality rates in the population group increases. So this is, we are trying to correlate the cigarette sales with the coronary artery disease. So this is a correlation which we do in a correlational ecological studies. And the analysis at the end of a correlational study is that we measure what is known as the R, or the correlation coefficient. So we measure the linear relationship between the exposure and the disease, and the range of R is -1 to +1. Higher the R, the better is the correlation, right? So this is correlation study, and this is a study which we carry out in groups. Now the studies which we carry out, descriptive studies which we carry out in individuals, okay, the advantages of this are quick and inexpensive, as data is readily available and we generate a hypothesis. But the disadvantage is it is not possible to link an exposure and disease on an individual level. We cannot control for the various confounding factors. The confounding factors we will be dealing in detail later on. Now, the descriptive studies which are held at individual levels are firstly case reports. Now, the investigator reports the details about a case that is having an unusual specific disease or condition which needs further detailed studies. Like in your cases, you must be seeing so many cases of dental pathologies. Now, if you find a case which is having an unusual specific disease or condition, then you report it. So this is known as a case report of an unusual specific disease. Now, the investigator reports details about a case that is having an unusual specific disease or condition. For example, a clinician among others reported hepatocellular adenoma, which is a rare tumor in women who had taken oral contraceptives. Now, a large case control study. So initially he carried out this descriptive study, and he observed that the cases of benign hepatocellular adenomas were common in those women who were taking oral contraceptives. So he formulated an hypothesis that oral contraceptives are associated with hepatocellular adenomas. But here it is an association, not necessarily that the oral contraceptives are contributing to the benign hepatocellular adenoma. Now, having formulated this hypothesis that there is an association between oral and hepatocellular, then he would proceed to test his hypothesis. And for testing the hypothesis, he needs to do a large case control study will be carried out and confirm whether the association, how strong is the association. When we talk of case control studies, we will be discussing about what is known as the odds ratio. And when we talk about the cohort studies, we'll be talking about the relative risks. So a case report is could be even a single case. And based on those cases, he may just formulate a hypothesis. Similarly, a case series report. A case series report is nothing but a series of case reports. That means if you find similar cases, 3 or 4 cases of the same disease, unusual disease, then you report all the cases as a series. So that is a case series report. For example, a cluster of homosexual men in Los Angeles with a clinical syndrome alerted the medical community to the AIDS epidemic in North America. 8 cases of pneumocystis carinii at 3 Los Angeles hospitals during a 6-month period in 1980-81. So when he observed these unusual cases, among homosexuals, he reported a series of cases. There were a number of cases. So he made case reports of all the cases, and then that becomes a case series report. Whereas a report of a single unusual case might not trigger further investigation, a case series of several unusual cases, that is in excess of what might be expected, adds to the concern. Then investigative studies are groups of subjects or individuals. Now we come to the third type of descriptive study, that is the cross-sectional study, or these are also known as prevalence studies. In this, the investigator studies a group of subjects or individuals selected from the defined study population oblique the community at a fixed point or within a short period of time. Now, I'd just like to elaborate on this. The investigator studies a group of subjects or individuals selected from a defined study population. Suppose when you are doing a study, you must have been told by, I think the earlier speaker yesterday, Dr. Kalra was talking of sample size and sampling. And there he had told you about the universe, the study population, and the sample population. So you decide on your sample and you carry out the study at a fixed point or within a short period of time. Now here, all the selected subjects or individuals are examined. That means you have decided on a sample, you have decided how to collect your sample of the individuals, and then all the selected subjects or individuals are examined, observed, or interviewed, and information collected at a single point of time. In a cross-sectional study, usually we collect one reading from one person. We do not follow up and go in for a second reading. For example, if we are trying to find out the prevalence of hypertension, for which we are carrying out a cross-sectional study, then we would go to the community or the hospital base or whatever we have decided, whatever our sample is, and in all the subjects, we will measure their blood pressure at a given point in time. Similarly, if in a dental caries, if you are going to a school and you want to carry out a prevalence study, that means you want to find out what is the prevalence of dental caries in the school children, then you would go to the school, examine the child once and see whether he has dental caries or not. And you do not again call the same individual for a second time for examining him. So in a cross-sectional study, we only take one reading. For example, your research question in a cross-sectional descriptive study would be, what is the prevalence of a certain disease? As I said, let's say dental caries. Is there any pattern of the prevalence of specified disease or condition according to characteristics of person, place, and time? This means, is there any pattern of the prevalence of this, let us say, dental caries according to the characteristics of person? That means, is there a particular age group which is affected, or is there a children of certain area are affected, or is there during these years than these years? That means the distribution of the characteristics according to person, place, and time. Then we also, what is the existing distribution of the variables of interest with respect to characteristics of person, place, and time? Then what is the prevalence of the risk factor of a disease of public health importance? Suppose you want to find out what is the prevalence of risk factor. Let's say hyperlipidemia in coronary artery disease. So what you want to find out the prevalence, that means how many people are having hyperlipidemia. So you are trying to find out the prevalence of a risk factor of a disease which is of some public health importance. Now, besides describing a disease in terms of time, person, and place, the end point can be developing a hypothesis. As I said, at the end of a descriptive study, you land up formulating a hypothesis or developing a hypothesis. Please be clear that a descriptive study cannot help you in testing a hypothesis. It can only help you in formulating a hypothesis. Help in assessing the load of the disease, or what are the resources that are required. What is the pattern of health utilization practices and knowledge or attitude towards the disease? For example, a lot of studies have now been carried out during this pandemic, like what was the knowledge and attitude and practices of the people to hand hygiene or hand washing, or what is their attitude towards getting the vaccine. So these cross-sectional studies help us to know the load of the disease, what resources may be required, what are the patterns of health utilization, and what are the knowledge, attitude, and practices. They also help in identifying the target groups. That is, as I said, if you carry out a survey of dental caries and you find that certain children are affected, then you would know that these are the target groups against whom you have to carry out certain measures to see that the incidence, the prevalence is reduced. Now, let us see some examples of cross-sectional studies. You may carry out a cross-sectional descriptive study to determine the prevalence of hypertension among males of age 40 to 60 years in rural area and its distribution with respect to the characteristics of person, place, and time. So if you see, your research question has been formulated very specifically. That is, you are trying what type of study you are doing? Cross-sectional descriptive study. And what are you trying to find out? Prevalence of hypertension. Which is your target population, or which is the population in whom you intend to carry out the study? They are the males of age group 40 to 60 years. In which area? In a rural area. And you also try to find out the distribution with respect to characteristics of person, place, and time. Another example of a cross-sectional descriptive study would be to determine the level of awareness about HIV/AIDS among students of class 12th studying in central schools located, or the third would be a KAP study regarding family planning practices among married women in the reproductive age in an urban area. So these are some of the examples of descriptive cross-sectional studies. Then what are the applications of this cross-sectional study or the descriptive study? How do you utilize the results of these descriptive studies? The information about the distribution of a disease according to person, place, and time could be used for understanding the extent and nature of the health problems. That means you can use the findings of this cross-sectional study or the descriptive study to understand the extent and nature of the health problems, to determine the health needs and priorities of the population among whom you have carried out the study, to determine who is getting the disease, where is the disease occurring, and is it changing in time. This is same as determining the person, place, and time of the disease. Or it could be also used for planning, implementing, and evaluating public health programs or health policies to control and prevent the disease. This means once you have carried out a study and you know these are the target population, then you can plan some health policies targeted towards the affected group or towards the target group. You can also lay down the priorities, which are the diseases which are more common. You can find out by the help of a descriptive study. And when you allocate resources, you can allocate your resources accordingly. More resources for the diseases which are more prevalent, more resources for the diseases which are a major public health problem. As you all know, how do we decide whether a disease is a major public health problem or not? A major public health problem, a disease is said to be a major public health problem if the mortality is very high. That would be your number one priority, to reduce the mortality of the disease. Then those which have mortality, morbidity, then you would target the disease which has a high morbidity. Then thirdly, you would target a disease which affects the vulnerable groups, the women and the children. So thus, a descriptive study will help you how to identify the target groups and set priorities and allocate resources according to the priorities. Other applications would be the health surveillance to study the changing pattern of a disease or distribution of a certain variable in the population or community over a time. So you will be able to understand the pattern of the disease which is changing with time. Now, what are the advantages of a cross-sectional study? The biggest advantage is least expensive, because there is always a crunch of funds. Whenever you carry out any study, resources are limited. So these cross-sectional studies are least expensive, no need for the outcome to occur. The outcome has already occurred. For example, if we are trying to find out the prevalence of dental caries, now you do not wait for a cross-sectional study, you do not wait for dental caries to occur. The dental caries has already occurred, and you are just trying to find out the prevalence or the target groups or the distribution of dental caries with respect to time, person, or place. So there is no need to wait for the outcome to occur. There is no loss to follow. All the cases are there. Usually, loss to follow up occurs in studies when you need to follow up the subjects over a period of time. Over a period of time, the subject may not report to you, and there is a lot of attrition, which we will be covering in cohort studies. Since there is no need to time for the outcome to occur, there is no loss of follow-up, and hence it is a very quick study. A cross-sectional study is the quickest. It is a snapshot of the health experience of a population at a specific time. Now, a descriptive study is a snapshot. That means things as they are at this given moment. Whereas other studies like a cohort study would be like a video clip. You would try to follow it over a period of time. Hence, you are taking a video clip. Whereas in this, you are taking a snapshot. So it is a snapshot of the. Then it provides the distribution of a variable of interest. Again, it is a repetition. It provides the distribution of a variable of interest with respect to characteristics of person, place, and time. One can study a number of exposures, oblique diseases, oblique characteristics of interest in a study. Now, this will depend upon your question. Now, whenever you carry out a study, you will either formulate a questionnaire. Now, when you formulate a questionnaire, you can include a number of exposures in this. Have you been smoking? Have you been chewing tobacco? Have you been having, what is the type of life you have sedentary? So you can study a number of exposures or disease of interest in that particular study. Again, as I told you, it helps to generate the hypothesis about the association of the relationship of the disease or the condition with determinants or risk factors or the protective factors. Now, let us see what are the disadvantages of a cross-sectional study. It is not suitable when the disease or condition is rare. We will come later. For a rare disease, we generally carry out a case control study to study whether there is a causation between the risk factor and the disease or not. For a rare study, we cannot carry out cross-sectional study because we will get very few cases. Since it identifies only existing or prevalent cases at a given point of time, hence a disease of short duration is underrepresented. Suppose you try to find out the study of tetanus or rabies. Now, this is a disease of a short duration. Hence, it will be underrepresented. Should try to find out the prevalence of rabies as of now, because most of the cases of rabies would have died within 2 or 3 days. So then, because of the short duration of the disease will be underrepresented. It may suffer from survivor bias. As I said, the case of rabies have died. So it will suffer from survivor bias. So now, when do you carry out the cross-sectional studies, or what are the indications of cross-sectional studies? When you have to study the distribution of disease occurrence according to the characteristics of person, place, or thing. Describing the existing distribution of variables of interest with respect to characteristics of person, place, and thing. Then you carry out a cross-sectional or a descriptive study. Determining the prevalence of various risk factors of a disease of public health importance. Say you want to find out the prevalence of risk factors of oral cancer. So then you can carry out a descriptive study. Now let us come to the steps of carrying out a cross-sectional studies. First thing is, as I told you, you have to define the objectives of your study. Then you define from whom sample will be selected. Then you define the disease or the health problems which you are studying. Now, this definition of the disease should be an operational definition, and the diagnostic criteria should be laid down. Now, what do you mean by an operational definition? A clinic, since in most of the studies where you have to study a large number of people, then you take the help of the paramedics or the other health workers to identify the problem in the population. Now, if you give them a clinical diagnosis, it may not be feasible. So you form an operational diagnosis. Say you must describe the ulcer in such a way, oral ulcer, in such a way that even a paramedic would understand and will be able to identify. So that is an operational diagnosis, and this would be called a probable case. And there are, as you know, there are three terms: probable case, suspected case, and lab confirmed case. So when you are carrying out a cross-sectional study where you are taking the help of the health workers, then you need to have an operational definition. And secondly, you should also have the diagnostic criteria of the disease as to which people will be included in your study. For example, if you are carrying out a study on carcinoma, then you should say that I will include only stage 1 cases or stage 2 cases. So the diagnostic criteria and the stage of the disease should be clearly defined. Then you have to decide the design for drawing the sample from the population. As yesterday, Dr. Kalra has already discussed regarding sampling. So you should decide what is the sampling design you will take. And of course, you will have to estimate the sample size. Now, what is I'm sure he must have covered the importance of sample size and the sampling technique. Because if you want your study to be valid, to be extrapolated to the population for which it has been designed, then you should have a representative sample and adequate sample. For a representative sample, you need to follow the correct sampling technique. And for adequate sample, you need to estimate the sample size according to the various techniques explained to you yesterday. So a sample should be both representative and adequate. Then only you can apply the findings of your study to the population to whom you are targeting. Then you have to make a list of the variables to be studied. Then you prepare your questionnaire, decide upon the sample size, collect your data by using pre-tested questionnaire. Then you carry out the measurements on the study subjects to be made on a single occasion. As I said, on a single occasion. In cross-sectional studies, all measurements are made on a single occasion. Then you analyze. Then each variable is to be analyzed separately and in relation to the relevant variable in pairs. Now, what does this mean? In relation to the relevant variables in pairs. Suppose you suspect that through your review of literature, you have found that the disease which you are studying is more common in a certain age group or in males or females. So then you make relevant pairs. Say age group, you divide the age group into various groups and find out the prevalence in each group. And then you see in which age group it is more prevalent. So you analyze each variable separately and in relation to the relevant variables in pairs. Then at the end, you formulate a hypothesis. Now, statistical analysis of cross-sectional descriptive studies. As I have already told you, there is not much of statistical analysis which can be done. The following are the commonly carried out statistical analysis if main variable of interest is dichotomous. That means yes, no. That is a dichotomous. Now, determine the prevalence of a disease condition and the desired level of confidence interval. As I had already told you, you can find out the percentage of children suffering from, let's say, dental caries. So here, the variable of interest is dichotomous. That is, dental caries present or absent. So at the end of the study, you will find out how many have dental caries, how many do not have dental caries, and what is the 95% confidence limit. This again details would be beyond the purview of this lecture. Hence, I will not be covering about confidence interval, 95% confidence interval, standard deviation. So but suffice here to say that we determine the prevalence of the disease at the desired level of confidence interval. Then determine the distribution of prevalence of a disease with respect to characteristic of person, place, or time. As I said, who are the person who are commonly involved? In the person, you could take their age, you could take their occupation, you could take their addiction habits, you could decide on the gender. So you determine the distribution of prevalence of a disease with respect to characteristics of person, place, and time, and the association between them using chi-square test. Yes. If you have to find out the association between a variable and the disease, then you use the chi-square test. The following are commonly carried out statistical analysis if the main variable of interest is quantitative data. Just, like I told you earlier, if the variable is dichotomous, then you find out the prevalence, and if it is if it is a quantitative data, then you determine the mean, the median of a variable of interest, and the desired level of confidence interval. Then you determine the distribution of the variable of interest with respect to characteristics of time, person, place. Now, what are longitudinal descriptive studies? Now, if you follow a single group of individuals over a defined period of time, then it is known as a longitudinal descriptive study. These are more scientific than cross-sectional studies, but more costly and more time-consuming. We can find out the incidence of a disease, describe the natural history of the disease, describe health-related natural phenomena, that is, study trend of a disease or health-related phenomena. Example, the trend of coronary artery disease in population. So these are longitudinal descriptive studies. Now, when you formulate a hypothesis, these are the various parts of the hypothesis. That is, when you are describing a hypothesis, then you should describe the population, that is, the characteristics of person to whom the hypothesis applies. Like in the previous example of hypertension, we had said it should be people in the age group of 40 to 60. The specific cause being considered. Here in this hypertension case, it may not be a cause, but if you are considering any cause, then you should also mention it in the hypothesis. The expected outcome, that is, what is the disease? In our case, it was hypertension. Now, dose-response relationship. Dose-response relationship would be applicable in the study of, say, lung cancer and smoking. That means you can find out the people who is smoking 10 cigarettes a day and one who is who is consuming 20 cigarettes a day. So then you will be able to find out the dose-response relationship. The time-response relationship similarly would mean a person who has been smoking for 5 years and a person who has been smoking for 10 years. So then you will find whether the people who are smoking for a longer time are more prone to develop lung cancer than those who have quit smoking earlier, let's say within a year. The time period that will lapse between exposure to cause and observation of the effect. So when you are formulating a hypothesis, all these things should be clearly mentioned in your hypothesis. Now, let us see some examples of research objectives. One is choice of study design. Example of research objective. To assess the extent of anemia and factors associated among school children aged 12 to 15 years in Pune city. So here in the objective, you have mentioned what are the outcome which you are going to study is the anemia, factors associated with it among the school children who are aged 12 to 15 years in, and where are you carrying out the study? In Pune city. A second example of the research objective would be to assess the prevalence of hyperlipidemia in IT professionals aged 40 years and above. To describe an association between cigarette smoking and oral cancers in Pune city. So these are some of the examples of research objectives. So choice of study design. Therefore, the design for in all these studies which we have mentioned earlier, the design has to be observational and not experimental. Now, let us consider some of the biases in observational studies. What are the biases that can occur? The following sources of biases will be discussed. That is the selection bias and the information bias. So what is selection bias? Selection mechanism in recruitment of the study population. That means if you do not use the correct sampling technique. Let us say you, suppose you are carrying out a study on oral hygiene and you ask for volunteers. Then those people who are really concerned about the oral hygiene will come in for your studies. So that would lead to what is known as a selection bias. Second type of bias which can occur is the selective recall or inconsistent collection bias. That is the information bias. Or you can also have measurement bias where the instrument is faulty. Once one is aware of the causes of the biased results, these can either be excluded or reduced by proper study planning. When the study population is not a random selection from the target population for which the statement is to be made, then the individual, then as I told you, it will be a selection bias. That means if you are asking for volunteers for oral hygiene, only those people will come up who are really concerned about their oral hygiene. Then in that case, the individuals would not be a representative of your target population. Hence, this type of a bias is known as a selection bias. Suppose, as I said, volunteers in a dental hygiene, or if you are carrying out a study on school children, and suppose you take up, suppose you are carrying out a study on dental hygiene among school children, and you carry out a study in children of a public school, or then there will be bias. Or if you are carrying out only in a rural area, where as it is the health hygiene is low. So if you want to carry out the study on health hygiene among school children, then your sample should be representative. It should include children both from rural areas, from urban areas, from public schools, from government schools, so that the sample which you collect is a representative samples, and then there is no bias in your study. Now, what is that? So that was selection bias. Now, what is information bias? Information bias occurs from wrong or inexact recording of individual factors, either the risk factors or the disease being studied. With continuous variables such as blood pressure, then this is known as a measurement bias. If it may be that your instrument is faulty, so that may lead to a measurement error, or it may be a misclassification bias, such as tumor stage. As I told you earlier, it could be the first stage, second stage, third stage. So you have to clearly have your diagnostic criteria spelled out, so that you does not lead to a misclassification bias. Measurement error or misclassification may result from lack of care by the investigator or from poor quality of measuring or survey instruments. However, they are more frequently caused by errors in the manner or the time of classification. Now, some of the typical errors, typical questions about events in the distant past. Now, suppose if you ask them to remember at what age did your child suffer from chickenpox and measles. Now, the mother may not be able to recollect properly. So that would lead to a recall bias. How much fruit did you eat last week? The answers to these questions will presumably be very imprecise. Or if you ask mothers of children with congenital malformation who would have a better memory of the potential risk factors during pregnancy than the other women. So these types of bias are known as recall bias. Now, what is interviewer bias? An interviewer treats patients during an interview with more sympathy than the controls. So there are various methods of excluding this bias, which we will see in experimental studies. like a blinding, single blinding, double blinding, and triple blinding. So that means if when you are asking questions, when the interviewer is asking questions to cases, he will ask more in deep and with sympathy than when he is asking the same questions to the controls. So this is known as the bias on the part of the interviewer, or that is the interviewer bias. This can partially be prevented by again good planning, but cannot always be corrected by statistical evaluation. Interviewer bias can be avoided with standardized interviews. Now, measurement errors, as I've already told you, systematic measurement errors may arise from wrongly calibrated instrument, imprecision of the instrument, measurement procedures, or human investigators. If the size and direction of the measurement error are known, this can be considered in the evaluation. So these details will be covered in the statistical analysis part. Now, ethical consideration, I'll not go into the details since these ethical considerations will be covered, I think have been covered yesterday. But as far as descriptive studies are concerned, this is critical in descriptive research just as they are in other types of research. Descriptive research designs actually have some benefits over experimental designs in terms of ethical issues. Descriptive designs have an advantage over experimental, because in experimental designs we are trying to intervene, we are trying to administer something, so that may lead to its side effects, or the person who have to be given will not be given, will be deprived of that. So the random assignment of test subject used in true experimental studies may expose a test subject to a potentially harmful treatment who would have not otherwise been exposed. The reverse may also happen. A beneficial treatment may be withheld from test subjects. These ethical concerns are not present in a descriptive study because it primarily studies participants and test subjects in the natural environment with no manipulation of any variables. I think I have done with my time, and after a break, I believe there's a break of 15 minutes, and then we will carry on with our analytical studies. Thank you. I finished.
Yes, sir. Yes, sir. We'll join at another 15 minutes break.
Hello.
Sir, yes, sir. 15 minutes ke baad we'll again rejoin, sir.
If there are any questions, I would not mind answering, or even if you want it after the break, come up with some questions, you are most welcome. Thank you.
Okay, sir.
Thank you. but the former is more likely.
No, sir,
Anyway.
students should have, they are taking some time. They will ask you, sir.
You're welcome anytime.
Yes, sir.
Okay, this again is a repetition that the studies are observational. Under the observational, we have descriptive and analytical. I've already talked about the descriptive study, and in this lecture, I'll be deliberating on analytical studies, that is both case control and cohort studies. So now let us see what are the steps of a cohort study. First, we have to define the population to be studied. Then we have to define the disease under study. Then we have to describe the disease by time, place, and person, measurement the disease, and compare it with the known indices. That was, as I had already told you, that descriptive studies is to formulate a hypothesis, and analytical studies helps us to test the hypothesis. Now, in a case control study, we proceed from the disease to the exposure. That means the disease and exposure have both occurred. And if a statistical association exists between the disease or the exposure or not, and what is the strength of the association. Say we want to find out whether there is an association between tobacco and oral cancer or not. And if there is an association, what is the strength of the association? So this will help us, we'll be able to do this with the help of case control studies and cohort studies. So let us start with case control studies. Now, case control studies are also known as retrospective studies. As we know, retrospective means looking back or backward looking study. We go back into the history. Now, there are three very important features of case control studies. One is both the exposure and the disease have occurred before the start of the studies. Because in the case control studies, what we are doing is we are selecting cases and we are selecting controls. Now, in the cases are those cases on whom the disease has already occurred. And since the disease has already occurred, it means they have already been exposed to the suspected risk factors. So we say that one of the features of a case control study is that both exposure and the disease should have occurred before the start of the study. Then second, we proceed from the effect to the cause. That means we study the disease and go backwards and measure the exposure. From among the cases, how many were exposed to the suspected factor, and among the controls who were exposed to the factor. So we proceed from the effect to the cause. And thirdly, we should have a control. May I request all to please mute themselves, please. And thirdly, we have to have a control group. So now one is cases. Cases are those who have already suffered from the disease or on whom the outcome has already occurred, and controls are those in whom the disease has not occurred. So, and we are comparing the cases to the controls as regards the exposure. So we proceed from the effect. So these are the three features of a case control study. Now let's see what are the steps of a case control study. Firstly, the first step of a case control study is to select the cases and the controls. Then second, we do matching. We'll come into more details about these steps. And thirdly, we measure the exposure, and then we carry out an analysis. Now, selection of cases and controls. Suppose we have to carry out a study on oral cancer. Then we'll have to select cases of oral cancer. So we'll have to define the case. Who is a case? We need to have both the diagnostic criteria and the eligibility criteria. Now, the diagnostic criteria, we may decide that all those cases who have been confirmed by biopsy as cases of oral cancer, they will be included in our study. Or that is, the cases which we take up would be cases of biopsy confirmed oral cancer. Then we have to also describe an eligibility criteria of the case. we may decide on taking up all the oral cancer cases which occurred in 2013, or we may decide to take all the oral cancer cases of a particular age group. So, or if there are staging of the cancers, then we may decide to take a particular stage of the cancer which we will like to include. So for the case, we got to describe both the diagnostic as well as the eligibility criteria. Now, having defined the case, we have to decide from where do we take the cases, or what would be the sources of cases. Now, they could be from a hospital. We may select all the cases of oral cancer which fit into the diagnostic and the eligibility criteria from a given hospital, or we may collect the cases from the general population. Like we will pick up only cases of oral cancer from the general population. Now, again, we have got to have controls, as the other feature was control, as we had discussed about the features. The first was the disease must have occurred. Hence, we have taken up the cases who have already suffered from the disease. Now, we got to select, and the cases can be selected either from the hospitals or the general population. Then we come to the control groups. Now, control groups, we have to decide how do we select the controls. Now, controls could also be selected from the hospitals, but what we have to ensure is that the cases must be, the controls must be similar to the cases as far as possible. They must be free from the disease under study, and they should be selected before the start of the study. Now, controls must be as similar to the cases as possible. Means that is what we call as matching. So we'll be coming, when we talk of matching, you will be able to understand what I mean by saying that the controls must be as similar to the cases as possible. Of course, there's no doubt that they should be free of the disease, hence they are called controls, and they should be selected before the start of the study. Now, let's see what could be the sources of controls. Now, sources of controls could also be from the hospital. Like we have selected cases of oral cancer patients from a given hospital. From the same hospital, we can select the controls. Now, controls could be patients suffering from any other disease other than oral cancer. So from the hospitals, we can have both oral cancer patient as cases and patients suffering from any disease other than oral cancer as controls. We can also have controls from among the relatives. They could be spouses or they could be siblings. Here, only one point of caution is that when we are selecting controls from among the relatives, we cannot do this in cases of diseases which are genetically determined. So in that case, we should not select controls from among the relatives. Or we could select controls from the neighborhood, that is from the locality or from the factory, or controls could also be from the general population, as long as they fulfill the criteria that they are not suffering from the disease under study and they are as similar to cases as similar to the cases in respect to various factors which can have an effect on the disease. Then how many controls? For each case, how many controls do you need to have? In a large study group, when your sample is large, so that is, if the cases are large, then you can have 1-to-1 control. That means for every case, you have a control. But if your study is among a small group, let's say less than 50, then you can have controls in the proportion of 1:2. That means for each case, you have 2 controls, 3 controls, or 4 controls for each case. So that will determine the cases and controls. Now, second thing is matching. As I had told you, the first step of a case control study is selection of cases and controls, and the second step is matching. So matching, what is matching? The cases and controls. That means they should be comparable. You cannot select, let's say you select cases of oral cancer. Now, oral cancer would either be in a particular age group, more common in age group. Whereas if in controls you select children, then these children are not comparable to the elderly people who are there in the cases. So the cases and controls should be comparable with respect to variables that have an effect of the disease under study. For example, if the disease is being affected by age, sex, socioeconomic status, or occupation, then your cases and controls should be comparable with respect to these factors like age, the sex, the socioeconomic status, and occupation, and various other variables which have an effect on the disease under study. Now, what is a confounding factor? As I had mentioned to you earlier, a confounding factor is a third factor or a variable. Now, a confounding factor is one factor that is associated with both exposure and disease and is distributed unequally in the study and the control group. So that is why we should match the cases and controls for the various confounding factors. That means a confounding variable is one which is related both to the exposure and the disease. An example of a confounding factor, an asbestos and lung cancer. In asbestos, a 40 to 50-year-old male working in asbestos factory would be suffering from asbestosis. So exposure to asbestos, the confounding factor here is the asbestos, because it can lead to both the lung cancer and also 40 to 50-year-old. Suppose we have cases who are 40 to 50-year-old males with lung cancer and controls 40 to 50-year-old males without lung cancer. Then the odds of lung cancer are 100 times more in asbestos factories. So if a person working in the asbestos factory is also a smoker, now smoking can also cause lung cancer, and exposure to asbestos can also cause lung cancer. So if we are studying the effect of lung cancer, if we are studying the effect of smoking on lung cancer and we select cases from the asbestos factory, then this occupation or the exposure to the asbestos would be a confounding factor. Then we will not be able to decide whether is it the asbestos exposure which has caused the lung cancer or whether it is the smoking which has caused the lung cancer. So if we are taking cases of lung cancer from asbestos factories, then controls should also be from the asbestos factories. That means in both the cases and controls, they should be comparable and both should be having asbestos if we want to find out the effect of smoking. But in this cases, we should avoid such confounding factors. Now, next. So 40 to 50-year-old males, if you take asbestos factories, many would be smokers, and controls if they are non-smokers. Smoking, and so the cases and controls will be unmatched. So we got to match the cases and controls for confounding factors, because this would lead to what is known as confounding bias. If so, asbestos will appear to be highly associated with lung cancers. Asbestos is, and smoking could be common among workers in asbestos factories, and smoking is a cause of lung cancer also. Now then, after having selected the cases, having selected the controls, then having matched the cases with the controls to avoid confounding bias, then what we do is we carry out the measurement of exposure. Now, exposure could be tobacco chewing or smoking. So we got to measure the risk factors, tobacco chewing and smoking. This could be done by the help of interviews or questionnaires or past records of cases such as hospital records or employment records. So we measure the exposure among the cases and the controls. In both, we got to measure the exposure with the help of interviews, questionnaires, or past records. And suppose we decide to measure the exposure by interviews, then it should exactly be the same way for both cases and controls. If it is by interviews, it should be both for cases and controls, we should take interviews. If it is by questionnaires, we should take questionnaires, administer the questionnaires both to the cases and controls. It should not be that we interview the cases and give a questionnaire to controls. No, it should be the same method should be employed for collection or measurement of exposure in both cases and controls. So here what we see is these are the diseased these are the non-diseased. Yeah. And then we measure the exposure, because the exposure has already, the disease has already occurred among the cases. Then we measure the exposure in both the diseased and the non-diseased, that is the cases and the controls, and compare the prior exposure. So this generally depicts that you will find that among the non-diseased, less number of people will be exposed as compared to case control, in which there will be more people will be exposed if the exposure is associated or causing the disease. That means from the present, we go to the past. The present, the disease has occurred, and we go to the past and measure the exposure. For example, in oral cancer, this is the diseased, these are the non-diseased, and then we compare with the prior exposure. There will be more among the cases than among the controls. So this is the control and this is the case. Now analysis. So having selected the cases and controls, having matched them, having measured the exposures, now we try to carry out an analysis of our findings. The analysis which we do in case of case control study is the odds ratio, or what it means is what are the odds that a person suffering from, let's say, oral cancer has been exposed to tobacco chewing. That would be the odds ratio. For example, we measure the strength of the association between the risk factor and the outcome. How strong is the association between the risk factor and the outcome? And this usually we do in cases of rare diseases. Case control study is carried out for rare diseases. Now, this is how we calculate the odds ratio. Now, suppose the suspected or the risk factor. We take cases, we take controls, then we see whether in how many cases was the risk factor present and how many cases it was absent. Right? So we see in how many cases the risk factor was present, or let us say if we are talking of tobacco chewing, then how many cases were chewing tobacco, let's say it's A, and C were not chewing. In controls also there would be some people who would be chewing tobacco, let's say that is B, and this D are the controls who are not chewing tobacco. Now the odds of exposure in cases is A by, now what is the chances of exposure in cases? A divided by C. The ratio, the cases would be A by C. Odds of exposure in controls would be B by D. So what would be the odds ratio? Odds ratio will be this divided by this. That is the odds ratio of exposure in cases divided by the odds ratio of exposure in controls. So when we say odds ratio, I take it as an odds ratio is a ratio of two ratios. An odds ratio is a ratio of two ratios. Now, what are these two ratios? One ratio is the odds of exposure in cases, and the other ratio is odds of exposure in controls. So, A by C divided by B by D, that is AD by BC. So, that is what is the odds ratio. So, the odds ratio is a ratio of two ratios. One ratio is the odds of exposure in cases, the other ratio is the odds of exposure in control, and the ratio of these two ratios is odds ratio. Now, what does odds ratio signify? Let's see it with an example. Suppose we are trying to find out the association of smoking and lung cancer. Among the cases, 33 were smokers and 2 were non-smokers. So what was the odds of exposure among the smokers? That will be A by C. And what would be the odds of exposure in the controls? 55 by 27. So if we take a ratio of these two ratios, then it will come to 8.1. Now, so this will show that lung cancer cases are 8 times more likely to be smokers. Please note one thing here. We are not saying that the smokers are 8 times more likely to get cancer. This is an example of lung cancer. So if the odds ratio is 8, it does not mean that smokers are 8 times more likely to have lung cancer. It does not mean this. In relative risk, when we are talking of cohort study, I will telling you if the relative risk is, let's say, 8, then it would mean that the smokers are 8 times more likely to get lung cancer. But an odds ratio of 8 means the lung cancer cases 8 times more likely to be smokers. Lung cancer cases are 8 times more likely to. Please note this difference. Odds ratio of 8 means that the lung cancer cases are 8 times more likely to be smokers. Whereas a relative risk of 8 would mean that smokers are 8 times more likely to get lung cancer. I hope this is clear. So when we talk of relative risk, we will again come back to this point. So this is the same example of oral cancer and tobacco chewers. Now tobacco chewers show 8 times. Now, so I'll just run through the case control study. In a case control study, the most important is that both the cause and the effect have occurred. It is a retrospective study, and the steps of a case control study are selection of cases and controls. Second is matching. The third is measurement of exposure, and fourth is analysis. Selection of cases could be from hospitals or general population. Selection of controls could be from hospitals, from relatives, from general population. Then we match the cases to the control to avoid confounding bias. And the ratio of cases to controls could be 1:1 in a large study, or it could be 1:2, 1:3, or 1:4 in case of a small study. Then we measure the exposure. Now, exposure can be measured by the help of interviews, questionnaires, or the past records. And the whatever method we use to measure the exposure should be same for both the cases and the controls. And after having measured the exposure, we try to find out the strength of the association of the suspected factor with the disease with the help of odds ratio. And odds ratio, as I said, is a ratio of 2 ratios. One ratio being the odds of exposure among cases to the odds of exposure among controls. And this gives us a odds ratio. And odds ratio means if we are studying, say, oral cancer and tobacco chewing, then an odds ratio of, let's say, 8 would mean that there are 8 times more chances of the oral cancer cases being tobacco chewers. So this is about the case control study. Now we come to the cohort study. Now, what do you mean by a cohort? Anybody? What do you mean by a cohort? Okay. A cohort is a group of people with certain common characteristics. That means the common characteristics could be, you can also be called a cohort, excluding the faculty. You can also be called a cohort of the first year MDS students. Or that means the common characteristics is that you all are students of first year MDS. Similarly, a cohort could be an age cohort, an occupational cohort. An age cohort would mean all the person, let's say, born during the year 1980. All the people born during 1980 can form a cohort. All the people aged 60 years maybe is a cohort. All the people working in a particular factory could be an occupational cohort. So a cohort is basically a group of people having a common characteristics. So these are the cohorts of soldiers. Now, a cohort study is also known as a prospective study or a longitudinal study. It is also known as an incidence study or a forward-looking study. Now, as we had seen in a case control study had 3 features. That is, both the exposure and the disease have occurred. It is a backward looking study. Similarly, we have 3 features of a cohort study. First, cohorts we select for the appearance of the disease. In a case control study, we had selected the cases after the disease has occurred. That means they are already suffering from the disease. But a cohort we select prior to the appearance of a disease. Secondly, we proceed from the cause to the effect. In a case control study, we were proceeding from the effect to the cause. We had the cases and we were trying to measure the exposure. Whereas here, the exposure will occur first and then the effect will occur. That means first they have been smoking or being exposed to the risk factors and then they have developed the disease. And here we determine the frequency of disease. So these are the three features of a cohort study. Now, cohort studies are of three types. One is prospective cohort, the other is retrospective cohort, and third is a combination of these two. Now, what is the prospective cohort? Now, you select a cohort. As I have already told you, a cohort means a group of people with similar characteristics. So you select a cohort and then follow them up over a period of time in future. So this will become a prospective study. Now, what is a retrospective study? In a retrospective study, you select a cohort in retrospect. For example, let's say in a prospective study, you take up certain subjects who are working in a factory where there is a chemical which can cause cancer. So you select the subjects and then follow them up in time to see how many of them develop some disease. So this is prospective. As in retrospective, what you do is you select same subjects who are working 10 years back, let's say, in a given factory. 10 years back, that is 2010. We'll take a cohort of people who are working in the factory in 2010. That is, in retrospect, we have selected the cohort. And then seen from the records, how many of them developed the disease. So this is called a retrospective study. Now, what is a combination study? Now, combination studies, let's say in a retrospect, you have selected workers who were working in the factory 10 years back. Then today you see how many of them developed the disease. And then you continue studying those workers in future for another 10 years. So then this becomes a combination of a retrospective and a prospective study. That means you have selected the cohort in retrospect, say 10 years back, studied them till today, how many of them have developed, continue studying them for another 10 years. So this becomes a combination of a retrospective and a prospective study. So these are the three types of cohort study. Now, what is a prospective cohort study? As I have already explained to you, a cohort type studies, exposed, non-exposed. Then we go forward in time, and then we compare the incidence between the exposed and the non-exposed. So from the present, we go forward and compare the incidence. That means we have taken a group of people, we study them, they undergo natural exposure, and from them, those who get exposed, how many are diseased, and from them who are non-exposed, how many develop disease. Like in this figure, it shows that those who were exposed, 3 of them develop the disease, and in this, those who are not exposed, only 1 develop the disease. And then we compare the incidence of these two. So although this is premature, but I'll just tell you here, since it's pictorially depicted, what are the chances that the exposed people will develop the disease? Clearly, it shows it is 3 times more. Then retrospective cohort study, as I already told you, you identify a cohort retrospectively. Example, employees of a tire factory. Then they have been exposed to the chemicals, and these are the non-exposed workers. That means you may take up, these are the people who work on the floor, and these are the workers who are working in the offices of those tire factories. So they will not be exposed, and these people will be exposed. Then you follow them up and determine and then compare the incidence. So this is a retrospective. Basically, the study is you are comparing the incidence till now, but you have selected the cohort retrospectively. So from the past, you come to the present. Now, combination, as I said, you identify cohort retrospectively, determine what happened to them, compare the incidence as of now, and then continue the study for another 10 years and determine what then happened to them. So this is a combination of study, retrospective study. Now, what are the steps of a cohort study? Sorry. First is you select the study subjects. As we said, you have to select subjects with a common characteristics. Let us continue with the example of the people working in a tire factory. So you select the subjects, that is, you select a required number of people as per your sample size estimation, that how many are there. You select the subjects, all those who are working in the tire factory. Then you obtain the data on exposure. How many were exposed to the chemicals? Then you select the comparison group. Then you follow them up, and after that you carry out a analysis. Now, as in a case control study, your study subjects here could be from among the general population, or you could select special groups. Like I said, there could be doctors or lawyers, or there could be exposure groups. This is the study groups or the cohorts which you are selecting. There could be exposure groups, example, those who have been exposed to radiation, those who are working in the radiology department. Then after that, you obtain data on exposure, as in a case control study, either through interviews, questionnaires, past records, or by medical examinations. Like in a radiology, you see the dosimeter, to how much dose of radiation they have been exposed to, or with environmental surveys. So having obtained the data on exposure, you see how many were exposed or non-exposed, and what has been the degree of exposure. Like what we were talking of, dose-response relationship in a descriptive study. So what has been the degree of exposure? Somebody must be smoking 1 packet a day, another one would be smoking 4 packets in a day. So that would give us the degree of exposure. So obtaining data on exposure, whether the person is exposed or not exposed. If exposed, then what has been the degree of exposure. Then after that, you make comparisons. Just. Now then you have to select the comparison group. Now comparisons could be internal comparisons or external comparisons. So external comparison would mean, suppose you are selected a cohort of people who are working in the radiology department. Then you calculate the incidence of cancer among the people who are working in the radiology department with the general population, or with the, let us say you can take, compare them with the incidence of cancer among those who are working in the labs. So this is called external comparison. Or you could compare the incidence of cancer among the people who are working in the radiology department with the national averages. What is the national average of incidence of this particular type of cancer? So you could make, this is what is known as external comparison. So the selection group, you have to select the comparison group, which could be external comparison or internal comparison. Now internal comparison, as I said, could be from the disease of degree of exposure. That means among these cohort, some would be smoking 1 packet a day, somebody would be smoking 4 packets a day. So you see whether those who are exposed, in whom the degree of exposure is more, what is the incidence of cancer, and in whom the degree of exposure is less, what is the incidence of cancer. So the comparison, you can make external comparisons or internal comparisons, or as I said, you can make comparisons with the general population. So then the next step is follow-up. Now in follow-up, what happens is, when it is a cohort study, since it takes a long time, suppose you are measuring the exposure with the development of lung cancer. Now development of lung cancer may take years to do. So initially when you start with a cohort, over a period, there may be some people who may drop out of the study. They may not be interested, and they may not come up for the follow-ups only. So this is what is known as attrition or dropouts. So when you are taking a sample, yesterday, like I think the person, doctor was talking of samples, estimation of sample size, had also said that we should take care of the attrition numbers also. That means if the estimated sample is X, then you should have at least 10% extra people to cater for the attrition which may occur in a cohort study. Right? And so then you follow up for the incidence of the new cases and find out the causal relationship or the etiological hypothesis. And then most important part in a cohort study, as in any other study, is the analysis. Now, what is the type of analysis we do in a cohort study? We find out what is known as the relative risk. So first we find out the incidence rates. Now, as you all know, incidence rates basically means the number of new cases divided by the susceptible population. That gives you the incidence into 100. So you find out the incidence rate among the exposed and the incidence rate among the unexposed. And then you find out, calculate what is known as the risk ratio or the relative risk. Now, the relative risk is more in this chap or this chap. So naturally, it is more in this, the one who has been exposed. So relative risk is the incidence of the disease among exposed divided by the disease incidence of the disease among non-exposed. I repeatedly like to draw your attention to the word incidence, because incidence is the number of new cases divided by the population at risk. Now here in a cohort, you have the complete population, your study population. So you have the susceptible population. The whole population which you have selected for your study is the susceptible population. So to calculate incidence, you need to know what is your susceptible population. In a cohort study, you can know the susceptible population. Hence, you can calculate the incidence. Whereas in a case control study, you have cases. So you cannot find out the incidence because you do not have the whole susceptible population. You have all the cases only. So in a case control study, you cannot calculate incidence. And since you cannot calculate incidence in a case control study, you cannot calculate the relative risk in a case control study. Relative risk cannot be calculated in a case control study. It can only be calculated in a cohort study, because in a cohort study, you will be able to find out the incidence, because incidence requires the denominator of the susceptible population, which you have in a cohort study, but not in a case control study. So you calculate the relative risk, that is incidence of disease among exposed divided by incidence of disease among non-exposed. And that gives you the relative risk. Say in this example, if you see tobacco chewers and non-tobacco chewers, those who develop disease, and among those who develop disease, how many were tobacco chewers, how many were non-tobacco chewers? Similarly, who did not develop disease, how many were tobacco chewers and how many were non-tobacco chewers? So incidence of disease will be among tobacco chewers will be 70 by 7,000, and that among non-tobacco chewers will be 3 by 3,000. 70 by 7,000, that is 10 per 1,000 among tobacco chewers. So in oral cancer, it will be incidence would be 10 per 1,000 because 70 by 7,000. So the population at risk is 70,000 and number of cases is 70. So incidence is equal to 70 by 7,000, that is 10 per 1,000. And here it would be similarly among the non-tobacco chewers, it will be 3 by 3,000, that is 1 per 1,000. So now what would be the relative risk? It would be 10 by 1. So incidence of disease among exposed is 10 per 1,000. Incidence of disease among non-exposed is 1 per 1,000. So the relative risk is 10. That means now here you see the difference of your interpretation. The risk of developing oral cancer was 10 times more in tobacco chewers as compared to non-tobacco chewers. Whereas in odds ratio, the interpretation was other way around. That is, the oral cancer cases are 10 times more likely, or that in that example, it was 8 times more likely to be chewers. right? So this is the difference in the interpretation of odds ratios and relative risk. And also I have told you why in a case control study you cannot calculate relative risk, but in a cohort study you can calculate the relative risk. So now come to biases in studies. Bias due to confounding, I have already told you. Memory or recall bias also I mentioned. Selection bias also has been mentioned, and interviewer bias has been mentioned. Now, bias due to confounding, which occurs in case of a case control study, as I told you, can be avoided by proper matching. Memory or a recall bias can be by only technique, because otherwise the memory of the person who is giving you the interview, it will depend on that. Selection bias can be avoided by proper sampling technique, and interviewer's bias can be avoided by blinding. Now, blinding is more important in experimental studies, hence it will be covered. Single blind, double blind, and triple blind would be covered in experimental studies. Memory or recall bias, as I have already mentioned, may not be able to recall correctly. Cases are more likely to recall the exposure than the controls. Selection biases, both cases and controls need to be representative of the general population. Interviewers who know the hypothesis may interview the cases more thoroughly. So blinding, if you blind him, you don't. If the interviewer does not know who is the case and who is the control, then he will interview everybody in the same manner, and hence the interviewer bias can be avoided. As I told you, single blinding, double blinding. Single blinding means the patient does not know whether he falls into the study group or the control group. This is more applicable, as I told you, in experimental studies. Double blinding means the interviewer and the patient and the investigator does not know group of the subject. In triple blinding, the interviewer, the subject, as well as the analyzer does not know which case is he analyzing. So single blind, double blind, and triple blind. So that's all I have to say about analytical studies. That's the case control study and the cohort studies. Now, if there are any questions?
Sir, we have few questions. Can we take up? Hello.
Yes.
Can we take a few questions, sir? We have few
Yes.
questions.
Yes.
Sir, there is one question. What type of sampling is considered as to be considered in case control study?
Sorry, what type of?
Sampling has to be considered during case control study.
No, he means to say the sampling technique or estimation of sample size.
Sampling technique.
Sorry, sampling technique.
What type of sampling is used in case control studies?
Yeah, if you are talking of the sampling technique, yes, then I would say here in case it is just the number of the sample number which is estimate what you estimate. Ultimately, the sampling technique, you have no choice. You have to take all the cases. So the cases are those who are suffering from the disease. Fine. Now, okay, let me give you an example. Suppose you have to carry out a case control study and you have to collect a sample of cases. Now, after having estimated the sample size, suppose you have decided that you will take up, as per the calculations, as per the formula which was yesterday explained by Dr. Kalra, suppose you decide you got to have 100 cases and 100 controls. Now, if you are planning a study in your D.Y. Patil Dental College and you see there are 400 cases coming into your OPD of that particular disease, then you need to collect 100 or the number which has been calculated as per the sample size. But if the number of cases to coming to your dental OPD is, let's say, 90 during your study period, then you can always mention in your dissertation that all the cases of this disease coming to my OPD will be taken up for the study. If that is, if the number of cases are less than the estimated sample size. But if you have the estimated sample size, then there is no question of sampling. Then you have to take 100 cases. Now, suppose out of 500 cases, you got to take 100 cases. Now, you can use other simple random sampling. That means, or you can allot them into two groups. They're the first patient which comes, you make chits. Let's say you make 100 chits. And out of 100 chits, you give the case a chit to pick up. And if he picks up that chit, you include him in the case, yes, no, yes, no. So it is to your imagination. How do you allocate them randomly? Out of 500, how do you calculate? Randomly select 100 cases is up to your imagination.
Sir, again, based on their eligibility criteria, no, not directly only just because they're entering into the OPD, we cannot change.
Sorry, your voice is slightly, volume is slightly low.
Sir, again, that depends upon the eligibility criteria which the cases and
Exactly.
because directly we cannot take whoever comes to our OPD. It has to depend, right? No.
You are absolutely right. You are absolutely right. First, before selecting the case, you have to decide on your eligibility and the diagnostic criteria. Yeah. And of the patients who fit into the eligibility and the diagnostic criteria, you have to select cases.
Yes, sir.
Only because the first step is the deciding on the eligibility criteria. Yeah. And only naturally you will only take those cases which fit into your eligibility criteria.
Yes, sir. Sir, one more question is there. How do we calculate the ratio of 1:3 for these estimations?
No, okay. You mean to say the ratio of cases to controls?
No, because the question is, how do we calculate the ratio as 1:3 for prospective and retrospective study?
No, sorry, I couldn't get your question. In a prospective or a retrospective study, where does the question of 1:3 come?
Exactly. Basically, they think the student might have confused between these cases and control.
Correct.
Usually, we take the cases 100 means 1:5 ratio. We usually take as control. Probably that is a confusion. So
correct.
It is to recollect this, probably to this student. If I want to tell, it is with respect to when you select the cases. If it is 100, then control should be 1:5 ratio. That is 150. So control should be always more than cases.
Now, the controls can also be 1:1. It is not necessarily that
1:1. Yeah, 1:1, depending upon the type of study which we are doing, and
depending on the not only the type of study but also the feasibility, doability. Yeah. If the sample size is, let us say 5, just for an empirical examine, then you can afford to have 1:4. But if your sample size is of cases is already 100, then probably you may not like to have 400 controls. Then in that case, you like to have 1:1. So it's basically the feasibility of the study which is possible in your case. The ratio depends upon that. Usually in smaller samples, we take more than 1:1. If it is a larger study, then we take 1:2. Sorry, we take 1:1. If it is a smaller study, we take more than 1:1.
Sir, one more question, sir. The difference between this external comparison and general comparison, when
yes.
you are taking in cohort study, can you little bit throw more light on this external comparison and general population?
Okay.
Comparison taking from external and comparison from general population.
Sorry, the difference between external and
general population. Because when you are comparing, there are 3 comparison. One is external comparison, one is internal comparison, one is from comparison from general population. Yeah. So what is external comparison?
In fact, general comparison with the general population would also fall under an external comparison only.
Yeah.
Would fall under external comparison only. Now, when we said external comparison and here we said general population, basically in the example which we are giving is, suppose in an hospital, if you are comparing the incidence of a particular type of carcinoma among the patients who are exposed to radiations, you can compare it with the patients working in the lab or those who are not exposed to the radiation. So, and general population would also in the true sense become an external comparison because it is not comparison within the group. Because when we talked of internal comparison, we talked of subjects who are exposed to, let's say, 1 packet of cigarette with those who are exposed to 4 packets of cigarettes. So that was correctly an internal comparison. Any other comparison would become an external comparison.
Sir, this interviewer's bias. Now,
yes.
Usually, whenever the interview is being conducted, is by from the investigator only. Now, you told there is something called as interviewer's bias only. How we can overcome or how we can minimize this interviewer's bias? Because usually he is the person or she is the person who is distributing the questionnaire. So obviously he or she will be aware about that what she is or what he is doing. Then how to minimize this or how to overcome this bias?
No, interviewer, yes, if he is a principal investigator, then the interviewer bias becomes a little difficult to overcome. But if he is not the principal investigator, suppose you are employing your other health workers or the medical social workers to collect the data, then you can blind the interviewer and let him not know whether this is a case or this is a control and ask questions about exposure. Then you can avoid interviewer bias as far as measurement of exposure is concerned.
Sir, but here then ethical issues will come, no conflict of interest, because I am proposing the researcher ethical committee that I will be collecting data and how I will give this work to another person outsourced to collect data. How to balance this?
At least in our setup, it is not always possible for the principal investigator to go in for collection of data. Let us say in community studies.
Yes, sir.
If you are having community studies, then we prepare a questionnaire and we give it to the medico-social workers to collect the data after informed consent and other ethical aspects are taken care
probably
of.
We can train them. We can train them how to collect data and how
exactly. Training is a part of the study.
Yeah.
Training
No,
the data.
Sir, that we can tell this to in front of ethical committee that I will be outsourcing this to some trained interviewer to collect.
True. Okay. True. Transparency should be there. Yeah.
Okay, sir.
And it is permitted.
It is ethically acceptable.
Yeah, it is acceptable.
Okay. Sir, one more question is there. Last question, if I'm not wrong. They should always, the question is read like this. They should always have a control group when you're doing study group. And if confounding factor not there, what is your opinion? No.
Sorry, I couldn't get the last part of the question.
Now, what student is trying to ask means, if there is no confounding factor, then what to do, how to proceed?
If there is a confounding factor, how to proceed?
If there is no confounding factor only, that's what he's understanding.
If there is no confounding factor, then there is no question of matching.
No, basically, no, sir. Confounders will be always be there, as you know, and we are aware. But probably, when the moment we do matching, the confounder factors are advised, and confounding bias will be reduced. We are overcoming the confounding factors and confounding bias by doing matching procedure. So
true.
That is, am I right?
Yeah, Dr. Karibas, Dr. Basava, you are correct.
Yes, sir. Okay, sir. Sir,
thank you.
No more questions have been left, sir. Thank you very much, sir, for giving your valuable time and sharing your expertise in this field, sir. On behalf of this Dental School and organizing team, I sincerely express my gratitude and thank you for sharing your, sir. Only thank you, sir. So
thank you very much
for giving your valuable expertise, opinion, and enlightening our students and faculty members with your expertise, sir. Thank you very much, sir. Looking forward in future to have you in our panel and support us, sir. Thank you very
my
much.
Pleasure. My pleasure. Thank you.
Thank you so much. Thank you very much. Bye, sir. Good day, sir.
Thank you.
Bye, sir. We have time. अभी gap है क्या थोड़ा? 1 minute.
overseas courses coordinator for Maharashtra Ayog Mandal. She has been handling a quarterly research journal as the managing editor. She is also engaged in clinical trial monitoring and fundraising activities for the institute as professor and research coordinator. She has a teaching experience of more than 15 years for global students to spread a right word for Ayurveda and yoga sciences. She is an experienced corporate wellness trainer for multinational companies for delivering speeches and wellness awareness trainings as per Ayurveda and yoga principles. She has been one of the most appreciated. She has been serving as the Vice President for Accreditation and Research in Goa State as a member of Indian Yoga Association Goa chapter. She has worked on 3 major international documentaries with the Dutch TV channels on various topics of Ayurveda, yoga, and meditation. She was awarded by the International Paul Harris Fellowship and Service Above Self Vocational Excellence Award by Rotary International for contributions to social welfare projects. With this, can I hand over to Madam? Pranita ma'am, please enlighten us.
Yeah, good morning, ma'am, and thank you so much for the kind introduction. I will just share my screen. Please enable the host rights. Yeah, just a minute. So let me know if my screen is visible to you all.
Yes, madam.
Yeah. So I hope I'm visible and audible, everyone.
Yes, madam.
Yes, thank you. So thank you so much for inviting me to deliver this talk. And I believe all the participants are here to brush up their knowledge and skills about various research domains. And this workshop specifies with the interesting title of Shodha. So this is nothing but getting access to various approaches of research, and one of them is like you from the morning you must have studied various designs of research and how we can incorporate those designs into our day-to-day activities, as well as in terms of writing a publication as well. So today my topic is about diagnostic test, and we all in some point or the other we are going to use the diagnostic test in our research, and to evaluate what is the correct diagnostic test and when to use it, what is the ideal format of using the diagnostic test is very important. So my topic for today is evaluation of a diagnostic test. And with that, I would like to highlight the learning objectives for today's session. First of all, we would like to know more about what is gold standard test. In COVID scenario, we have seen so many tests for confirmation of COVID, and also there are new tests coming up, new methods coming up to diagnose accurately. So there is still we are relying on one particular test as a gold standard test, and we want to know more about it. The second learning objective for today's session will be identifying the sensitivity and specificity of a test and what are they about. We need to also define them and how to calculate the sensitivity and specificity. We are going to learn that. Also, I'm focusing on likelihood ratio to choose a correct test. Like I mentioned, there are so many tests available, and to know the right test to be used in our research is very important. For example, I will just give you a very small example that initially when there were research trials being conducted on diabetes, we used to have just fasting sugar or postprandial sugar test. and we used to depend on it. But nowadays we are more into advanced testing, and we are more into HbA1c and other tests, which give us the most important average of say last 3 months. So that is more accurate, more correct test in today's research scenario. And there are so many new tests coming up. So how to choose a correct test, this likelihood ratio will tell us more about it. So first I will start with the basic difference between diagnostic test and screening test. Now, I believe all the participants are from first year of their post-graduation, and they are about to select their project. Okay, so I hope it is the right information I'm having.
Yes,
if
madam.
somebody,
Yes, madam.
yeah.
Yes, madam. Yes, madam.
So when you are trying to select the diagnostic test, you need to know that whether you are trying to determine the presence or absence of a disease when a subject shows sign or symptom. That means he is a patient, he or she is a patient with symptoms. And then to confirm that disease, you are going to use a test, and then we'll call it as a diagnostic test. We are going to diagnose a condition. Okay. If the patient is asymptomatic or the individual is asymptomatic, but he or she might have a disease, we will have a screening test. Okay, so that is the basic difference. A asymptomatic individual will be screened for the disease, underlying disease, if there is any. And in diagnostic, there are symptoms, and we need to confirm the presence or absence of a disease. Okay, so diagnostic test is performed after a positive screening test. That needs to be understood. Once the patient is confirmed that, okay, like suppose I just mentioned about the diabetes test. So somebody goes for a random sugar test and finds out that, okay, his readings are very high. And then maybe we will have a diagnostic test which will confirm that patient is suffering with diabetes or not. Okay, so after the screening test is done, generally we go for the diagnostic test. And that's why diagnostic test is very important in research, because the selection of individuals in a particular group, like you must have studied case controls design today. So cases, how you are going to say that this is a case of so and so disease only when a particular test is positive. So diagnostic test is very important to confirm the inclusion criteria for your cases. Some of the screening tests you must have been aware that these are the screening tests, like I mentioned about fasting blood sugar or fasting blood cholesterol. Like in terms of a screening test, we are just confirming that, okay, they are having something or the other as underlying element, and that needs to be diagnosed. Like in case of a blood cholesterol, higher cholesterol doesn't mean that a patient is already suffering with a heart disease. We will diagnose it later with a confirmatory test. Okay, so this difference we all need to know. Now, how we are going to select a diagnostic test? So the selection totally depends upon the intended use of the result. What exactly you're looking at? What is the intention of using that particular diagnostic test? Like suppose my intention is to rule out a disease. Okay, so reliable negative results are required. Am I clear? You can interrupt me anytime, because we are going to use positive and negative and disease rule in, rule out terms very frequently, and at the end you will be confused. So I don't want you all to be confused. Okay, so just interrupt me whenever you feel like overwhelming kind of information. So I just wanted to tell you that whenever you want to rule out a disease, that okay, a person is having a fever but RT-PCR is negative, so we are ruling out COVID. Okay, so whenever we are ruling out a disease, the reliable negative test results are important, and that is my intended use. Okay, for which a test with a high sensitivity, that means few false negative, never ever that test gives a false negative reading, then the high sensitivity test I will select. Okay, if my desired use is to confirm a diagnosis or find out evidence of a disease, that is rule in. Okay, so I want to confirm that the person is suffering with so and so cancer, then I'll go with some kind of a biomarker test which will confirm the diagnosis. clinical symptoms could be there, some of the other parameters could be there, patients might be suffering, or there could be a particular history. We are having like a 80% confirmation that, okay, he or she is suffering with this kind of a disease, but we are not yet confirming that. So when the intention is to confirm the underlying problem or the disease, we will say rule in the disease, okay? And then we need a high reliable positive result, high specificity. Okay, so we need to have something with a high specificity to rule in, to pinpoint that, okay, this is the disease. And to rule out, we need high sensitivity, high or few false negative results, okay, that we need to confirm. Now selecting a test, like I told you, nowadays we are having so many options for single disease. There are 4 or 5 tests available. Okay, so we need to decide that what is the test purpose, why a particular test is done. Like for example, biomarkers are there, some of the scans are there, sonographical evidences are there, even clinical examination or clinical confirmatory tests are there. So what is the purpose, why we are using that particular test, what is the purpose, where we are using it, and who is going to conduct it? That is very important. Okay, so is it a technician who is going to perform, or the doctor himself is going to perform the test? So decide whether an acute or chronic infection is to be diagnosed. Like it, because I'm just putting out a list so that you'll be in a condition to identify or select a test for your research project. Then we will also decide whether the test is to be used for diagnosis or disease modification or verifying a cure. So again, like I mentioned, what is my intended use? Whether I'm just using that test for diagnosis, or I'm just monitoring the disease. For example, in tuberculosis, we take multiple X-rays to see how the disease is prognosing to the treatment, how the disease is reacting to the treatment. Even in case of COVID, there was multiple testing done just to see how the patient is reacting to the treatment. So, and also we sometimes use the test to verify a cure, whether our medicines are appropriately being used. Decide, or for example, in terms of the bioactive ingredients or radioactive ingredients we use, and then we verify that, okay, our medicine is reaching to a particular cell, our medicine is reaching to a particular system, and then we verify a cure. Sometimes we need to decide whether the test should be quantitative or qualitative. Like I was discussing about a clinical test. There are tests to diagnose sciatica. It's a qualitative test, whether a person can lift his leg in a particular angle or not. So it's a qualitative, but we are converting that test into a degree of elevation of the foot. So that means we are converting that into a quantitative test. Sometimes the grip of the patient, present, absent, that is a qualitative test. So there are so many clinical quantitative and qualitative tests available. We also need to decide whether the test results will be analyzed at the point of care or in the central laboratory. Because if you are having a major survey of, say, anemia, okay, you are conducting a camp in a rural facility where you are just going with a particular test and you are conducting that test in the field where you are just screening the patients. Okay, I will just screen whether they are having anemia or not. If they're anemic, I'm not advising them for blood donation, and those who are passing the test, I will just screen them for the blood donation. So that way I need to decide whether I am conducting the test at the point of care or at the field or in a particular advanced laboratory. Okay, so this is the formula which we are going to see here. The sensitivity and specificity, these are the terms which we need to understand. Now we'll look at the diagram at the left side. Here you can see the sensitivity means true positives, and outside the circle there are false negatives. Okay, and similarly in specificity there are false positives, and outside the circle there are true negatives. Okay, so true negatives means they are negative and we are confirming that negative with the test, so that becomes true negative. So the formula becomes sensitivity we need to calculate with number of true positives, means patients with a disease and identified with a test as yes, they are having a disease, that becomes true positive, divided by number of true positives plus number of false negatives. So we want to take out the complete denominator, and then we will take out number of true positives divided by total number of individuals with the illness. Okay, and then we'll get a sensitivity of the test. Similarly, for specificity, here we, like I mentioned, we are trying to take out the true negatives. That means a person is definitely not having a disease. True negative. Okay, so number of true negatives divided by total number of true negatives plus true positives, false positives, sorry. So total number of individuals without the illness, because in specificity, we are ruling out a particular condition. In sensitivity, we want to confirm the diagnosis. Okay, so this is a very important differentiation between those two conditions. Now, like I mentioned, these are called as predictive values, positive and negative predictive values. And again, the likelihood ratio. This actually confirm this whole system of these various formulas. They help us to measure the diagnostic accuracy, how close we are in identifying or ruling in or ruling out a particular condition. Okay, so the gold standard test is now we have to how to calculate that whether our test is right or wrong. So what we do is we generally compare with the gold standard. And in medicine, as well as in statistics, we believe that a gold standard test is usually the diagnostic benchmark, okay, which is available right now in current condition. And it has been tried and tested multiple times. So gold standard is the most accurate test possible without restrictions. It is available. So what we do when we want to test that, okay, whether this new test is appropriate to be used, we compare that test with the gold standard. And then we decide that, okay, it is equivalent or more specific, more reliable than the gold standard, then we use it. Okay, so a comparison with gold standard is, first we need to require application in terms of like a particular disease spectrum. Like I mentioned, if we need to confirm the disease. The assessment or comparison of a diagnostic test require their application with gold standard. So am I able to confirm the disease just the way the gold standard confirms the disease spectrum? If yes, okay, I'm closer to the condition diagnostic. If the characteristic of the test are compared with the gold standard in terms of sensitivity and specificity both, I am more closer to the diagnostic standard. Okay, so that way we generally compare. Now, this I have already mentioned in the previous slide, that sensitivity is ability to test the disease correctly, like condition is present, the disease is present, is sensitivity. And specificity is identify whether they have or have not the particular disease. Okay, so specificity and sensitivity are very important markers in terms of any diagnostic test. So how do we do that? This is a general table, 2x2 table. Okay, so we are going to see so many tables in not only in terms of research designs, but in also diagnostic tests. Now here it is very simple. Okay, don't get confused. What we need to do is first, like I mentioned, we compare with the gold standard. So what we decide here, what is the status of a person according to the gold standard? Okay, so whether he is positive with RT-PCR or negative with RT-PCR. Okay, for example, I'm just taking a COVID example right now. But the second step here is whether the individual has the condition. Another point is whether the individual does not have the condition. Okay, like fever present, fever absent, like that. Then if the test, whatever you are screening, is coming as positive, then it is a true positive. because you are doing a test and it is coming positive, and the patient is having the, and let me just help you with this. Just a minute. Yeah. So if the person is tested positive with COVID, and that individual is also suffering with fever, and the test comes positive, that means it is a true positive. Am I clear here? So we are in the A bracket. Okay. Person is not having fever, but tested positive with your new screening test. That means it is a false positive, because gold standard was also negative for that particular patient. Okay, so that means the new test is telling us a false positive report. Okay, if the person is having a condition comes as a negative in your new test, it comes as a false negative. Okay, because our gold standard was saying that it is a RT-PCR positive case, but your test is saying negative. That means it is a false negative. Am I clear here? Okay. Then the fourth is true negative, which means that the person is not having any fever, and RT-PCR was also saying negative, and your new test also saying negative. So that means it is a true negative. Okay. So this has the condition column entries for determining sensitivity, whether we can capture it rightly. Are we sensitive enough to track the condition? Specificity is for determining whether the person is not having the condition. Okay, that we need to confirm again. So this is the formula we generally use. I have already mentioned that true positive divided by true positive plus false positive, everything together in the denominator versus true positive. So sensitivity is fixed characteristics of the test. Then again, specificity is true negative. We want true negatives. We want to rule out. Okay, specificity is ruling out. So true negative is our highlight, divided by all the negatives, total true negative and false negatives. So that is again a very important approach for the diagnostic test. Here again, I'm just giving one example. So disease present, and patient, total 50 patients are there. Okay, and with the say clinical symptoms or some basic, you can say that okay, symptoms are present. So the test comes as a positive. Okay, so that is true positive, 40 people. Test is negative, that means it is false negative. There are 10 such cases. Disease is absent, but still test is coming as positive, that means it is false positive. Okay, there are 20 such cases. Disease is absent, but still test is saying that it is positive, that means it is true negative. Okay, so 30 such cases. Now how we are going to calculate the sensitivity? We are just going with the 40, that is true positive. In terms of sensitivity, we are going with true positives. So 40 divided by all the positive, 40 plus 10, it comes as 80%. In specificity, we need true negatives. So 30 divided by all the negatives, 20 plus 30. So it is coming as 60%. So that means that this test, this particular diagnostic test, has a good sensitivity. It can capture the disease very well because true positives are higher, but poor specificity, because we are also getting false positives. Okay, so that's why we cannot rely on this test. However, it can capture the disease very well. Okay, so that way we need to calculate sensitivity and specificity for every diagnostic test before using in your research. And for that, we need to first decide the intended use, why we want to select a particular test, and then we can have a most appropriate result. So positive predictive value, PPV, is a term which we use for the proportion of a patient who tests positive and who actually has a disease. So we want higher number of PPV. That means we want that our test should be capturing the actual disease every time it is administered. Higher positive predictive value. Am I clear? Okay. If the proportion of patients who test negative, who are actually free of the disease, that means we also need a test which will give us the negative predictive value. And negative predictive value means if the test comes as negative, you are definitely negative for the condition. Like a urine pregnancy test kit. If the kit shows just one bar, that means it confirms that there is no pregnancy. Its negative predictive value is higher. Okay. If there are 2 bars, you are confirmed that the test is showing that the pregnancy is there and the patient is having the pregnancy. That means positive predictive value is also high. And that's why we are using that at home. Again, see the intended use of the test. So why we need to check so many aspects about a test? Because we want 3 major important criteria to evaluate a good diagnostic test. First of all, we want a test which is reproducible. Okay, everybody can use it, and no technical advancement is required. Like I have just told you that urine pregnancy test. Everybody can use it. At home, we can use it, and that is easily accessible. Repetitions are also possible. If you purchase 2 kits, you can again repeat it on the second kit. So repeatability is also possible and reliability is higher. So immediately the person can come to know the status of the condition. So all these 3 categories means that the result of a test or a measure are identical and closely associated every time the test is being conducted. Okay, so we want every test to pass on these 3 criteria. Now there is a possibility that variation in laboratory procedure, observer error, or changing condition of the test subject, or even sometimes the geographical location, they can alter the test. We want to know that what is the reliability of a particular condition under these many circumstances. Then sometimes we are also need to be aware about the physiological or psychological aspect of the individual on whom we are administering a test. For example, the blood pressure. You generally calculate the blood pressure in the OPD. And if a patient is not settled and he is having some anxiety, the BP will show higher reading. Okay. And there could be a chance that you will consider that reading as reliable and you will note down that it is that patient is hypertensive. But after some time, if somebody else repeats the test, it comes down absolutely normal. That means there was a physiological change. We need to settle down those aspects which will disturb the test outcome. Okay, so you need to be aware about such conditions. When this kind of a physiological alteration, a confounding error can come in the picture, we need to be aware about it. Okay. And then, like for example, even in the swab test, whatever swabs we collect, even in pap smear or a particular, even in RT-PCR, there is a collection of swab. If a collection is not done properly, there is a chance of error. Okay. So we need to be sure that what is the standard operating procedure for that particular test. And that's why when we use a particular test in our research trial, we always highlight standard operating procedure. Even in terms of a clinical setup, that suppose I am trying to diagnose a patient with sciatica, how I am going to administer a diagnostic test, how I am going to tell the patient, if suppose I am just calculating the blood pressure, what should be my standard operating procedure when I will measure the blood pressure? Shall I ask the patient to wait for 5-10 minutes to calm down and then I will measure? What will be the position of the patient, standing, sitting, lying down? So every factor which may alter the outcome, I am trying to avoid that with the standard operating procedure, and automatically you will give us the more reproducibility, more repeatability and reliability for the test. why I'm highlighting on this? Because in research scenario, we are very much depending on these three criteria. For example, suppose I'm trying to repeat a particular research design. Somebody is working on, say, a condition of, say, tuberculosis, okay? And they have captured the X-ray findings of a patient. And when the X-ray was captured, what was the what was the time of the X-ray capture, how many times the X-ray was captured, and what was the position, where exactly it was done, was it the same laboratory or not, everything will be followed up. And suppose the next individual wants to take up the same study, they will follow up the same thing and try to repeat the outcome. They will try to repeat the overall diagnostic criteria, so that there will be less observation error or observer variation. Okay. Then I'm not going to go into these details of ROC curve, but I'll just tell you one thing, that this is a statistical analysis of the test. Like suppose I want to try out a fasting blood sugar sample, and after 2 hours, and versus a new test, then I need to compare these things with the gold standard. So this is a ROC curve. We call it as receiver operating characteristics of the curve, and the AUC is area under the curve. Okay, so what we generally do, on y-axis we put the sensitivity, on x-axis we put 1 minus specificity. Okay, why this 1 minus specificity? Because we are here ruling out, that's why. So the outcome should be maximizing the sensitivity corresponding to some large value on y-axis. So as the value on y-axis goes on increasing, the sensitivity goes on increasing. And specificity is corresponding to some small values on the x-axis. So we want to have a test which is having, say, in the area of 3, but here on the x-axis it should be having a lesser value. So we want to correspond to a small value on x-axis and large value on y-axis. Okay, so good first choice will be the one corresponding to upper left corner. Okay, so automatically you are trying to identifying a good test in terms of area under the curve and receiver corresponding value. So this is something slightly you can say technical, but try to understand that whenever you try to select a particular test, go for this analysis and then decide where my test is falling in the area of 1 or 2 or 3, and what is my intended use, and can I select this particular test for my research trial. Okay, so just I'm putting up this information for you. Even if you don't understand, don't get overwhelmed by it. You can decide the use of the test and then ask for that particular calculation. Now there is a third approach for deciding a test. We call it as likelihood ratio. Now likelihood ratio is nothing but how to measure the accuracy of the test. Okay, so it is defined as the ratio of expected test result in a subject with a certain disease to the subject without the disease. So suppose I am using a particular test with an expected test result of positive, because patient is having so and so condition, and I know that that condition is detectable by my test. Okay, so I am using that test with an expected test result of positive. I hope I am not confusing you all, but I just wanted to make sure that you understand this concept, because likelihood ratio is very important. For example, I'll just tell you one quick example for this. Suppose I want to test fever, and I'm using a thermometer as my tool, and my intended use is capturing the fever in particular Celsius or Fahrenheit. Okay, so expected test result should be higher range on the thermometer. That is my expected value, right? Because the person is suffering with fever. I know he is having a higher temperature. So that thermometer must capture higher temperature. Am I okay? Am I clear here? So ratio of expected test results in subject with fever divided by the subjects without the fever will give me the likelihood ratio. What is the likelihood of your test to capture a condition becomes the higher likelihood ratio. So that ratio tells us how many times more likely a particular test results in the subject with the disease than without disease. So if a subject is suffering with the fever and I could successfully capture the fever with my thermometer, and same thermometer if I use in the normal individual, it doesn't capture the higher degrees of temperature. That means my thermometer is accurately useful for detecting the fever in a particular patient. And that's why higher likelihood ratio is there. And I can select that test. I can select that particular tool. So when both the probabilities are equal, that means the likelihood ratio is 1, that and then we can use that particular test. When both the probabilities are equal, such test is of no value. 1 divided by 1 will be of 0. It will be not having any importance because the thermometer cannot capture the fever with the condition and without the condition. So same numbers will be 0. We want LR, the LR will be 1. Okay. So to rule in, like I mentioned in my previous slide, if you want to rule in a disease condition that, okay, a person is suffering with fever, my likelihood ratio should be positive. That means sensitivity divided by 1 minus specificity. And to rule out a condition that, okay, a person is not suffering with fever, I need to have a negative test. That means 1 minus sensitivity divided by specificity. So this you need to properly put it in the mind that, okay, whenever we are trying to confirm the condition, our test should give a positive test. Okay. If you want to rule out a condition that, okay, a person is not suffering with the condition, your test should give us a negative test value. Okay. And that means you are just identifying the likelihood ratio. If the ratio is positive, sensitivity divided by 1 minus specificity, you can rule in. If the ratio is negative, 1 minus sensitivity divided by specificity, you can rule out a condition. Okay. And in various differential diagnostics, we use this technique. So you must have been aware that fever is something which is nowadays a troublesome factor. We want to know what is the infection, what kind of a bacteria or virus is involved, or if there is any other condition or inflammation or other infection happening in the body. We run so many tests and we try to rule out one condition. So it's like a deduction method. There are 4 possible diagnoses for a fever. Out of those 4 possible diagnoses, we are using a particular test, maybe 4 types of test, to rule out every condition. And when everything rules out, something remains. To confirm that condition, we again use a test and try to rule in that, okay, this is the confirmed diagnosis, and that is why patient is suffering with fever. Okay, so both the aspects are very important, and both the aspects can be cleared and characterized by the likelihood ratio. Okay, so I'm not going much into the technicalities of it, but I'm just trying to, because this is a basic research workshop, I don't want to scare you off that this is something which is very alien concept and we can, but I want to make you aware that you need to know the sensitivity and specificity of the test. Okay, so this is just a total, you can say, a summary slide. Suppose patients with bowel cancer, and endoscopy confirms that. That means endoscopy is a gold standard. Gold standard says the condition is positive because patients are already suffering with the condition. Okay. So condition positive and your screening test outcome, say fecal occult blood, also comes positive. That means your test is able to capture this particular condition. True positives are 20. Okay. And if your screening test comes as negative, it is showing false negative because that condition is already positive. You can see the column. Sensitivity should be there. So your screening test is having a sensitivity of 67% because it is able to capture the true positives 20 divided by all the positives, true and false. So it's 20 plus 10. So our sensitivity is coming near to 67%. So it's a good sensitivity, I must say. And if my test is showing false negatives as 180, false positives as 180, when the condition is negative, patients are not having the cancer, and your test is also coming as false positive, that means it is showing 180 as more number, whereas true negatives are more. So specificity in terms of where we are focused on true negatives, that if there is no condition, our test must confirm that there is no condition. That means true negatives are more. So automatically our number goes up in the sensitivity, specificity. So 1820 divided by all the negatives. And that's why it is coming as 91%. So the test, fecal occult blood test, is showing higher sensitivity and higher specificity. So we can use it for our screening pro forma. So that could become a good criteria to select the diagnostic test. And when we cannot do endoscopy all the time, okay? So, but this test is a screening test that could be done anywhere, and that needs less technical knowledge. A simple laboratory technician can also do that, whereas endoscopy needs skilled manpower. So in terms of confirming whether I can use such kind of screening test or no, I need to put this table and I need to see whether my test is able to capture the disease where we want to rule in, or whether my test rule out the other conditions. So this way we can actually confirm, and then the positive predictive value is 10%, but negative predictive value is 99.5%. So if there is no occult blood in the stool, that means patient is 99.5% not suffering with cancer. Okay, so I can do this test in the field, I can do this test in OPD basis. But if somebody comes with the positive screening test, then positive predictive value is 10%. That okay, I need to confirm with the endoscopy. Okay, we will not confirm only based on the occult blood present or not. So that gives us a good advantage that, okay, in terms of a research trial, we can use a occult blood test rather than going to the endoscopy. Now, one more point I wanted to clarify here, that every time the gold standard cannot be applied in the research design, because you are doing post-graduation and sometimes the fund is limited, sometimes the resources are very limited, and you want to have a good trial. So, and you want to work on, say, bowel cancer, but there is less fund available. So never say that, okay, because I cannot afford these many tests, I am selecting only 30 patients. You need not go for that. You can have screening for 100 patients with occult blood testing, because you are sure now that if there is no occult blood, there is no cancer for 99% times. Okay, so you can use this test for 100 patients, and whenever that test comes as positive, say in 10% of the cases, it comes positive. That means now for only those 10%, you can use endoscopy and confirm it. So what you are doing, rather than using it for 100 patients endoscopy, you are coming down to hardly 10 cases. automatically you are not compromising the quality of research. You are not compromised on what question you want to ask to the patient, how you want to screen out the population, but you can definitely have a good research project in hand with limited resources. I will also give one more example here. For example, I want to screen breast cancer ladies from the rural population, okay? And generally, in terms of surveys, in terms of our post-graduation research, we generally take epidemiological researches. So what happens, but for every rural individual or every rural woman, we cannot do mammography, right? And it is not feasible to take them to the hospital and do the mammography. So we need to go to the outskirts. We need to go on the field and do a clinical breast examination. Okay. So suppose clinical breast examination is a screening test now. And that is a test which you want to rely on, whether you can use that test in your research or not. You can put similar table here. And it is now proven that clinical breast examination, if shows there is a lump or some growth in the tissue, it generally can be confirmed with mammography afterward, and it is found to be positive. So similarly, it comes as 90-10. So you can screen many patients with in rural condition, in rural setup, and then you can go ahead with the mammography. So automatically you are reducing the burden on the project. So this is all about the diagnostic test and how we can evaluate the correct diagnostic test. These are some of the references I have used. So this is my contact detail if you want to ask anything. That is all from my side. I hope I am on time and I could complete that topic.
Yes, ma'am.
Thank you so much.
Yes, ma'am. Thank you for a great presentation. I think the floor is open for any questions.
Yes. I'll just stop this presentation. Yeah. Yes.
Madam.
Yes.
Can we take up the questions?
Yes, sir.
Madam, now, when you are selecting a screening test or a diagnostic test, usually we should check for eye sensitivity and eye specificity. The test we have.
Sir, your voice is very low.
Sir, now am I audible, madam?
Yes, sir.
Madam, now when we select a test, screening test or a diagnostic test, the test should have eye sensitivity and eye specificity.
Yeah, it's no, it is not like that. The thumb rule is not like that. See, that's why I was mentioning the intended use. Okay.
Yeah, exactly, madam. Operational definition, we will give the operational definition for our dissertation or for research.
Right.
And accordingly, we'll select the test. But now usually we go for 90% of sensitivity and all. But exactly what I'm trying to tell here is there any guideline that there should be minimum this much of percentage should that test should possess to select as the test for our purpose? Minimum percentage sensitivity, this much of minimum percentage of sensitivity that test should possess. Then only I can consider that for my research.
Okay.
Is there any guideline like that?
Okay, actually, sir, that's why I was mentioning that when
likelihood ratio, you told about something about likelihood ratio, exactly you told that. But what is that? How much we should consider that, madam? Because when you give the example of 1 by 1, but what should be that ratio which we should consider when we are accepting for our methodology section?
Okay.
Yeah. So hopefully, I hope I addressed that question.
Yes. Yeah. See, like in my presentation, I have used one illustration of, say, occult blood. Now, if you go ahead with the just mention that, okay, I need high sensitivity and high specificity, that occult blood test is not going to qualify on that rating, right? So what we generally do for selecting a test, we need to know what is the purpose of my test. Whether I'm using my test to rule in or to rule out. That should be the first question in mind. If you want to say confirm the diagnosis, okay, then I should go and focus on the false negatives. Few false negatives should be there with high sensitivity. If I want to rule out the disease, then I want to focus with high sensitivity. You go beyond 90% if you want to have a thumb rule.
Exactly.
But if your desired intent is to confirm the diagnosis, now you need high specificity. a test which will confirm the true positives. Okay. So in this way, I need to first decide that what is my intended use. Do I need to rule in or rule out? Okay. Then if the my requirement is few false negative, I should go with the highest sensitivity. If the requirement is reliable true positives, I should go with high specificity. So generally it is 90-60, 90-70 generally they say, but again it depends on the intended rule. So that's why
there is no mandatory like percentage, means
no mandatory percentage. Yes, there is no mandatory percentage as such, because what happens, when you in your research design, generally what happens, you are the total, like you rightly said about the operational definition, you are in total position to decide who is to be included and at what range they need to be included. So suppose you say that, okay, I want 95% sensitivity and say 75% specificity. It should be your rule of thumb for your condition.
So I as an investigator, I can set that percentage. This much will be my sensitivity and this much will be some specificity.
Yeah.
Is it acceptable at research level when we are sending for grants or when you are?
Yes, but see, when you are sending for grants,
that's what exactly I wanted to know.
Yeah, that is a good question. When you are sending for grants and you are not just evaluating any diagnostic test, you need to compare with the gold standard.
Madam, we will compare with gold standard.
So
But gold standard,
in terms of
when I'm comparing with gold standard, when I'm selecting other alternative tests, what should be that sensitivity percentage which I should choose?
So that is what I exactly right now told you, that 90% and 70% should be the range.
90% and 70%. Okay.
Yeah. So that way I can say that it is closer to the gold standard. Nothing else.
As close as possible to the
gold as standard. Possible closer to the gold standard.
Yeah.
So like I mentioned about, because you are asking for grant. Okay.
Yeah. Because our students are there, no? So
yeah. So if the grant gets evaluated and they will ask you that, okay, why you are selecting this particular test?
Exactly, madam.
Then you will say that, okay, this test is having at least 95% sensitivity and 75% specificity, yes, as compared to the gold standard.
Gold standard. Yes, madam.
And that's why I am selecting it.
Selecting this. Okay, madam.
Now the second approach could be there, that if there is no such gold standard available and it is a completely new test, you yourself can decide that, okay, for me, I am putting it as 95-70, 90-70 or 98-75. You can put it that, okay, my test should have this much of sensitivity.
Madam, for that, first I should do some pilot study, no? For my new design test, exactly. I have to do, then I have to do the table, graph, then you see,
exactly.
Repeatedly I have done this test, I got this sensitivity and specificity, so I am choosing this as my test.
Exactly. That's why I have given you that table at the end, that if you are trying with a new test, always go and put the values in that table, calculate the sensitivity and specificity. You decide that, okay, after screening 10, 15, 20, 100 patients, I am getting this range and I am happy with this range for my particular trial. So I am selecting this range.
Yes, madam.
When the gold standard is not available. When gold standard is available, you can go closer to the gold standard.
90 and 70 as you told.
Yes, yes. Okay.
Any more questions?
Other queries?
I will see, madam. Just I will see. As such, there are no queries, madam, here in the chat box. So can we take break and again we can come back after break, madam?
Yes, yes, sure. So,
madam, as such schedule now is your next session is on experimental studies then. So after lunch, so can we rejoin again at 1:30, madam?
Yes, we can rejoin at 1:30. No problem.
Okay, madam. Okay, madam. Thank you. Thank you.
Thank you so much.
Thank you, madam. Hey, today's now this session is very important. People, all of you people might be useful for you. This session, experimental designs.
Yeah, is it visible now?
Yes, madam. Yes, madam.
Okay, okay. Yeah, sir rightly said that this is very important topic, and you must have seen today all the observational trials, descriptive studies. Now the main focus is about experimental studies, and today I'll be discussing few major important aspect of it. So the learning objectives are very clear. What are the types? How to achieve those steps in a clinical setup? How to do randomization, and what is about blinding. So we are trying to understand various types of experimental setup, and then at the end of this lecture we are having a short group study. So what we are going to do is, I hope there are groups already made in the workshop.
Yes, madam. Yes, madam. We have made a group. We can do this in Zoom also. We can directly make the group. Whenever you tell, we will create that randomly. We will make the 5 groups.
Okay, okay. So what we'll do is, at the end of the presentation, all the 5 groups need to identify any one type of study design which is into experimental setup, and they can discuss it out. Okay,
Yes,
so
yes,
we
madam.
will clarify the doubts if there are any, and then we can take it further. So every group will, at the end, again they'll come back in the main meeting, and we will have a short quiz. Okay.
Yes, madam. Yes, madam.
So this is the requirement of why we conduct clinical trials. So they are nothing but the methodological approach to achieve the excellence, and excellence in terms of evidence creation. And this evidence is in terms of safety or efficacy, or sometimes both, for the drug. So in clinical setup, we experiment, we methodologically plan the trial so that at the end we will achieve some evidences about our treatment plan. And they are now also being tested for new molecules. We are also, now you must be having many clinical trials in dentistry also, where you are trying newer drugs, newer therapies, newer surgeries, and you are trying to compare with the established mode of care. And then you are at the end try to create an evidence and tell that which one is more safe, more effective. Okay. So you must be now aware about this pyramid. I think from the morning you are having a whole understanding about the quality of evidence. So as we go up in the pyramid, the quality of evidence improves. It is considered as the highest quality of evidence. So when we start with, say, just background information, some of the expert opinions, or just some folk medicine, or some of the maybe case series, you develop some kind of evidences that, okay, this is the treatment available, and we can create some of the safety or efficacy related evidences. As you go up in the pyramid, you try to identify the mentioned treatment modalities in case series or cohort designs. Then you again, because this is whole observational setup, right from just the background information, just an individual case in our OPD, or just set of 10 cases in our college or hospital, that becomes a case series, and these are all observational designs. Then you come to know that now I need to try out this observation in an experimental setup. Okay. And basically, the major difference between observational and experimental is the investigator assigns the experiment. He manipulates the intervention. Okay. So that's the basic difference. In observational studies, investigators are just observing what is happening. What are the clinical pictures, how the patient is reacting to the treatment, what is the presentation of the disease, how a particular drug is being used, what are the modalities of the drug, what is the dosage of the drug. We are just observing. We are not creating any manipulation in the intervention. Okay. Then at the experimental level, we try to assign the intervention. So we are now the captain of the ship, and then we say that, okay, this is our intervention. And intervention means, can anybody tell me what is the definition of intervention? Anyone? Like they can unmute themselves and talk, because I know this is a post-lunch session. I need to make sure that everybody is awake and they are interactive. So can anyone tell me what is intervention? Anyone? You can also put it in the chat box. Anyone can unmute themselves and they can talk. What is an intervention? You must have heard this word for quite a few times now.
Is it making a point? Putting your point across?
Okay, but how you are making a point?
Like a second opinion?
No. See, why we are using this term intervention is, even if you think in terms of a mere simple English term, okay, intervention. That means it is intercepting, interacting, or being in the middle of something. Okay, you are interfering with some flow. You are changing something. So intervention means anything which changes the course of the disease, or the prognosis of the disease, or the current condition of the health, is an intervention. Now, it is not necessary that when you are using an intervention, there must be a patient. You can also use intervention for healthy volunteers, healthy participants. Like just saying that, okay, do not take junk food, have restricted salt in your food. That is also an intervention, because you're stopping something, you're advising something. A consultation or counseling session where you are understanding the patient's feelings, where you are trying to tell them what to do when they feel down, or when they feel depressed, or when they have a panic attack, and you are trying to have a counseling. That is also an intervention. Okay, so anything which changes the course of disease, or the prognosis of the disease, or the health status of the individual, is intervention. Okay, so intervention could be dietary items, there could be something related to the therapy, there could be a surgery happening, or a drug administration, or some healthy, you can say, lifestyle choices. They can all become intervention. Okay, so the moment investigator, you as a researcher, decide that, okay, I want to give this intervention to my patients or to healthy individual, that becomes an experimental setup. Okay, because initially you were not assigning any intervention, you are just observing. Now, observational studies, you must have seen, we are going to see that chart also, that suppose I'm observing two sets of people, one who are having a sedentary lifestyle and one who are having active lifestyle. I'm just observing them, and I'm just at the end of say 3 months or 6 months, I will see that who are having more BMI than other set. That becomes mere observational trial. The moment I say that, okay, I will identify these two sets of individuals, one with sedentary lifestyle, one with active, and I will assign exercises to the sedentary group of people, that becomes my experimental setup. Okay, and then the quality of evidence goes up. Okay, because you are doing something and checking the outcome. And that is why the non-randomized control trials or randomized control trials come in the picture. At the end of this experiment, you will have some of the outcomes. And if you conduct so many experiments on one particular drug or one particular therapy, then you will be in a position to critically appraise the literature, to critically say that, okay, this works, this doesn't work. Okay, or say if you are trying to establish a regime for weight loss, you will say that, okay, this A, B, C together works better than alone. So what is happening here? You are in a better condition to critically appraise the results. And that becomes all the more higher evidence in the clinical setup. So then critically appraised literature, evidence-based medicine, systematic reviews, meta-analysis will come in the picture. In meta-analysis, what we do, we just collect, say, all the clinical trials done in last 10 years on various approaches for health promotion. Like what kind of lifestyle changes should be done so that we can have a good quality of life. And all the trials can be compared. We can analyze what are the measures they are taking, and we can critically appraise that literature. That becomes a meta-analysis. So these are the quality of evidences. And today our focus is on the experimental studies in the mid section of the pyramid. Okay. So, like I mentioned, when exposure or the intervention is not manipulated by the investigator, it becomes merely observational design. There are two types in it again, analytical and descriptive. Analytical has cohort and case control, you have already studied in the morning. And descriptive also they are covered, case series, cross-sectional, ecological, they are all descriptive studies. When it comes to the manipulation of the exposure or intervention, it becomes experimental, and there we are describing all sorts of clinical trials. Okay. So out of those clinical trials, RCTs, which we fondly call, like they are called randomized control trial. Now it is not randomized clinical trial, it is not randomized control clinical trial, it is just randomized control trial. Okay, so RCT is one of the based model where you can check evidences, where you can generate outcomes which are related to safety and efficacy, and they are considered as a gold standard for scientific experiments. Okay, so we are going to see RCT at the end. But why there is such an importance to clinical trial is because we as a researcher in terms of a clinical setup, because see, our research is not about a machine. Our research is not about just a drug formulation. We are trying to use that machine or drug on the individual, and we are dealing with life and death. So to say something about it, we need to have a good illustration with good evidences in hand, maybe so that we can prevent some of the diseases, we can diagnose some of the diseases in right time and treat diseases, and also manage the rehabilitative conditions. So clinical trials are at most importance considering the nature of our service. There are now again two setups of clinical trial. One is just a planned experiment where you are trying to establish a prophylactic effect or diagnostic or therapeutic. In your case, in dentistry, now there are so many experiments going on in terms of prophylactic measures, that how to prevent dental caries, how to prevent these particular issues in, say, in Indian population. And for that, what kind of teeth brushing regimes we need to follow, what kind of dietary factors we need to consider, what kind of, you can say, beverages are healthy for tooth or not. So what are these prophylactic agents we are focusing nowadays on a very large scale. So they are planned experiments. And the second part of the clinical trial is about comparing the outcomes. So just the way we talk about the diagnostic test, we always need to compare. Why this comparison is important? I'll just tell you one example, that we often say that if you treat flu, like a common flu, it gets cured in 1 week. Okay. If you are giving some medicine, it is getting cured in 1 week. If you are not giving any medicine, it is going to be cured in 7 days. So what is the difference of your treatment? Like, so why we want a comparator? We want to prove that our medicine is something different than the existing course of the disease. It can change the course of the disease. It can have safer outcomes, more effective outcomes, and that's why we need a comparator. Like, okay, so in those TV serials, there used to be a mention of Sharma ji ka beta, है ना? हमेशा शर्मा जी के बेटे के साथ ही कंपैरिजन क्यों? Because he was a good boy, like he was meritorious student, sincere, obedient. So every quality was there. So everything was compared with Sharma ji ka beta. So what is happening here? In terms of a clinical setup, we are trying to compare with standard of care. So standard of care से अच्छा अगर medicine है, standard of care से safe है, standard of care से feasible है in terms of practicability, in terms of cost effectiveness, तो आप बोल सकते हो कि इसको choose करो rather than the standard of care. That's why comparison, a control group is very important, because students generally say that control group is favorite for guide, इसलिए बार बार बोलते रहते control group लो, ऐसा नहीं है. कंट्रोल ग्रुप गाइड का फेवरेट नहीं है. कंट्रोल ग्रुप क्लिनिकल ट्रायल के सेटअप में बहुत इंपॉर्टेंट है, बिकॉज कंट्रोल ग्रुप गिव्स यू मोर एडवांटेज ऑफ टॉकिंग दैट ओके दिस इज बेटर देन द एग्जिस्टिंग वन, एंड दैट इज अदरवाइज इट इज लाइक इन आयुर्वेद वी कॉल इट एज यदृच्छा. कुछ नहीं करने से भी ठीक होने वाला है, कुछ करने से भी ठीक होने वाला है, तो क्या फर्क पड़ा है? व्हाट इज द डिफरेंस बिटवीन ट्रायल ड्रग एंड द existing drug? So that's why we want to have a comparator. And in clinical trials, in experimental trials, comparator is very important. Okay. In the objectives of trial, National Institute of Health, NIH, USA, they have identified these 4 areas where clinical trials are very important. If you want to prove some of the prophylaxis like immunization or contraception, you need to have a clinical trial. If you want to talk about a drug treatment or a surgical procedure, how effective they are in management of a particular disease or a condition, you need to have a clinical trial. If you want to talk about side effects of drugs and inform about the safety, conduct a trial. If you need to do a risk factor trial, like which one is more in terms of cause and effect kind of a thing, like smoking is more risky in cardiac patient. If you want to have a trial for that this is more important risk factor in causing a particular condition, conduct a clinical trial. So that is why experimental trials are very important in establishing all these 4 areas. Okay. Now, when general outline of a clinical setup is, you identify a sample from the population, okay, and then you randomize the sample, okay. So treatment 1 and treatment 2. Say treatment 1 is your new modified updated treatment and treatment 2 is an old one or existing standard of care. And then you have a periodic follow-up and have ultimate readings, post-test or intervention. You just conduct the intervention and then you conduct a post-test analysis. So what is happening on the time frame, you are starting today and following the patients in the future till they develop some kind of outcome or effect. Okay, so this is a general structure of any clinical setup. Now, can anyone tell me ये sample selection करना क्यों जरूरी है? Why we want a sample from population? ऐसे कोई भी ले लिया randomly तो नहीं होगा क्या? Can anybody tell me why it is important to have a sample from the population suffering from the disease? Can anyone tell me about it?
For generalizability.
Generalizability, true. So generalizability is about saying that, okay, I have treated 50 patients with hypertension using XYZ drug. So all the hypertensive patients in the world can be treated with this drug. Okay, so this is called a generalizability. That means whatever outcome I'm getting with the help of just 50 patients, I can talk about 500 patients or say 5,000 patients. Now, to talk about 5,000 or 500 patients, I need to select my sample in such a way that it is representative for the population. Okay. If I want to work on a dentistry research project, I need to collect all the researches related to the prophylactic trials in dentistry or therapeutic trials in dentistry, and then I can say something about it. That okay, in dentistry, current trends, current research thirst areas are so and so, and this is the current update. But if I try to take all the healthcare sciences together and talk about dentistry, it will not be a good approach. Okay, so always I need to have a representative sample of the population to talk about the population. Otherwise, it is difficult. Now, in terms of experimental setup, there are these 4 or 5 designs. There are actually so many designs, but I'm trying to just focus on these important few designs. What is the true experimental design, which we call it as pre-test, post-test, randomized design. Second is quasi-experimental. Third is Solomon 4-group design. And there are factorial designs, there are crossover designs. So we'll just have a look at one by one. Then there is a pre-post, which is called as a true experimental design. What we do, we collect a sample from population, identified population, and then whatever the appropriate sample is there, we assign those people into 2 groups with a randomization approach. Why randomization is important? Why we do randomization?
To overcome bias.
To overcome bias. Okay. So suppose I am undertaking a trial on, say, if I teach on PowerPoint presentation in the classroom, I believe that I can illustrate more effectively about, say, a surgical procedure or a dental procedure. And for the other classroom, I am using the old technique, just chalk and board method. And then what I do, all the intelligent student, I put it in the PowerPoint group. And then I'll say that, okay, see, they are getting more benefit. They are getting more marks in the exam. So that means PowerPoint is effective tool. What is happening here? I am creating a bias that already those who are aware about the that particular syllabus point, I'm selecting them and giving the illustration or giving the intervention. Now, what is happening? I am not assigning equal opportunity to both the groups to come in the trial. So randomization helps an individual to have a equal opportunity. I can select with a bias as an investigator. Even the participant can select with a bias that, okay, ये medicine ज़्यादा अच्छी लग रही है, I'll go into this group. इस group में कुछ नहीं देने वाले, तो मैं इस group में नहीं जाऊँगा. तो ऐसे selection bias हो सकता है, participation bias हो सकता है, and I am not able to give the equal opportunity to everyone. So what I do, I'll just have a randomization technique. एक lottery method हो सकती है, एक random selection हो सकता है, computerized generated sequence हो सकती है, and then I'll assign those patients into equal groups. So randomization is very important in reducing bias and giving equal opportunity to all the participants. And then I'll again go into the time factor and will expose the individuals to the treatment. And before that, I will have a pre-testing done. So what is pre-testing? Pre-testing is nothing but capturing all the important data points in your treatment. Suppose you are looking at a patient who is suffering with, say, some kind of a joint pain. And you will capture all the indicators of swelling, pain, mobility, and quality of life before administration of the intervention. And then you will give the medicine. After the intervention, say 15 days, 1 month, you will again have the post-test. Post-test is again calculating the swelling, pain, mobility, everything, whatever you have done in the pre-test. And then you will compare both the things. So pre-test and post-test comparison is happening here. That is a true experimental setup. Now what happens in quasi-experimental design, or they are also called as before-after studies. and we also sometimes call them factorial design. See, what happens in research is we make simpler things complex. And इसलिए सबको लगता है कि नहीं आएगा. But it is not that. If you understand the basic structure of any design, it is very easy to understand कि आपको करना क्या है, what exactly you want to prove, or which design will be more suitable. तो factorial design में क्या होता है? That randomization you are not doing. Everything else is same. Okay, so इसमें हम hypothesis test कर रहे हैं, but without the randomization. So this will be the case. Randomization कर रहे हैं, so it becomes randomization kind of a trial with a true experiment nature. We call it as true experimental trial. अगर mic on है, please mute करिएगा. I can't see the name.
Sorry, madam, I will inform.
Yeah, so randomization is there, then it is a true experiment. अगर आप randomization नहीं कर रहे हो, but there are comparators, there are multiple groups involved, तो वो quasi experiment है. अगर comparator नहीं है और randomization भी नहीं है, तो उसको हम बोलते हैं non experimental trial. ठीक है, तो इसको इस तरह से we can imagine that suppose 2+ groups we identified, और उनको अलग अलग इसमें डिवाइड कर लिया दोनों ग्रुप में. पहले हमने देख लिया एलिजिबिलिटी क्या हो रही है, किसने रिफ्यूज हो सकता है ट्रायल के लिए. यू हैव अ बेसलाइन मेजरमेंट्स इन द प्री टेस्ट एंड देन यू डिवाइड देम विदाउट रैंडमाइजेशन. इट इज अप टू यू हाउ यू आर गोइंग टू डिवाइड. इंक्लूजन एक्सक्लूजन क्राइटेरियाज लगा के एंड देन यू कैन डिवाइड देम अप, एंड आफ्टर डिविजन देन यू गिव देम द इंटरवेंशन. अदर ग्रुप विल रिसीव स्टैंडर्ड ऑफ केयर or alternative intervention, and then again post test will be done. So that becomes a simple quasi experiment. जो third type है Solomon 4 group design. This is a very nice design. Here what is happening is random allocation is there, but there are 2 groups for treatment and 2 groups for control or no treatment. So with this design, you are in a position to say that if you are not administrating the treatment, still your treatment is giving more effects than no treatment. So because like I mentioned about flu, if you give the treatment, it gets well in 1 week. If you are not giving the treatment, it gets over in 7 days. So that should not be the case. And to overcome that fact, you are understanding this with the 4 group study. So group A and group B will be measured. Then they will be having a treatment or no treatment. Then group C and group D, normal course of individuals who will not be having any pre-test data, but they will be in the study. Afterwards, all these 4 groups will have a post-test and they will be compared. So 4 group design gives us more advantage in terms of setting the trial in the normal environment. आप जो चीज क्लिनिकल सेटअप में कर रहे हो उसी को एक कम्युनिटी सेटअप में भी पैरेलली यू आर ट्राइंग टू कंपेयर. So Solomon 4 group designs gives you more advantage in terms of stating that even if you are not measuring anyone, even if you are not having a inclusion exclusion setup, आप इसको ट्रीटमेंट दोगे तो भी इसमें इफेक्ट दिखेगा. फॉर एग्जाम्पल स्टीम इनहेलेशन है ना, तो स्टीम इनहेलेशंस वी हैव प्रिस्क्राइब टू एवरीबडी इन कोविड पेंडेमिक. तो स्टीम इनहेलेशन देने के पहले किसी का चेकअप नहीं किया था कम्युनिटी में, राइट? हमने किसी का बेसलाइन इन्वेस्टिगेशंस हमने करे नहीं है, प्री टेस्ट करा नहीं है, बट वी कैन एडवाइज कि स्टीम इनहेलेशन करो. वॉट एवर द कंडीशन दे आर सफरिंग विद, दे कैन हैव स्टीम इनहेलेशन एंड आफ्टरवर्ड्स वी कैन हैव देयर पोस्ट टेस्ट रीडिंग्स. सो दिस सेटअप गिव्स अस 2 groups advantage. One set of group is for the treatment, one in the clinical setup, one in the community setup, one in the again for no treatment also similarly, and then you are comparing all the factors together and you are following them up in the time. So if you have a look at the experimental designs, there are 3 basic divisions. First is true experimental, where you are having a pre-test, post-test kind of a thing, or Solomon for group design, or post-test only control group design, where two groups are there, you are not doing pre-test, directly post-test is administered. So this is called as true experiment. Quasi experiment में randomization नहीं है, rest of the things can be similar. बाकी ट्रू और quasi में उतना ही difference है, randomization नहीं हो रहा है. प्री एक्सपेरिमेंट में फिर वन फैक्टर केस स्टडी, मल्टीपल फैक्टर्स, देन कंपैरेटर्स वाले केसेस आ सकते हैं, वेयर यू आर ट्राइंग टू कंपेयर द ट्रीटमेंट मोडेलिटीज. फैक्टर मींस ट्रीटमेंट मोडेलिटीज. सो उसमें भी यू कैन हैव अ प्री एक्सपेरिमेंटल सेटअप जहां पे यू आर ट्राइंग टू डिसाइड द नेचर ऑफ एक्सपेरिमेंट, पर आप डायरेक्टली उसको सेटअप में नहीं ला रहे हो. फॉर एग्जाम्पल, if I want to conduct a trial and I'm having 3 modalities of treatment. So what I'll do is, in clinical setup, I can have that comparison with less number of participants. I can call it as a case study based experiment. And then at the end, I can decide, okay, B and C are giving more results. So let us compare B and C only in the true experimental setup. Let us keep A. So that advantage I get in the pre-experimental setup. Then there are again crossover designs where we are understanding this crossover because it is a part of clinical setup, but generally crossover designs are sometimes needed to prove that one person gets treatment drug and also standard drug together, and that's why crossovers are important. So we start with the study participant, we randomize them in treatment A and treatment B. Say for a period of 15 days that treatment is going on. After 15 days, you again have an assessment of the patients. You give a washout period. Now, what is washout period? After the treatment is done, it should get out of the system, because some drugs take a lot of time in to get down from the blood levels. So after the liver excretions are done, the kidney excretions are done and everything, there are some time durations for every drug. So we consider sometimes 15 days, that after 15 days, there will be no drug in the system. And then we change the groups. So group A, जिसको पहले हमने drug दिया था, now they will receive say standard of care. दूसरों को जिसको हमने पहले स्टैंडर्ड ऑफ केयर दिया था उसको अभी ट्रायल ड्रग मिल रहा है. सो व्हाट इज हैपनिंग, वन इंडिविजुअल इज गेटिंग स्टैंडर्ड ऑफ केयर आल्सो एंड द क्लिनिकल ड्रग आल्सो, एंड दे कैन टेल अस दैट व्हाट वाज द डिफरेंस व्हेन दे वर ऑन द क्लिनिकल ट्रायल and when they were having standard of care. So that gives us additional inputs that what is one-to-one, a personalized approach of the drug in both the setups in the same person. So that gives us more advantage in crossover design, but they are very difficult to undertake, how to manage the washout period, how to change the groups of the patients, that sometimes is very it takes time and lots of planning and lots of funds sometimes. So but this is a good design to consider the effect of same drug in one individual with 2 modalities. Then it comes to the RCTs. So like we mentioned, randomized controlled trial. So controlled means not only that they are having a comparator as a control group, but that also means that they are undertaken in a controlled setup. Everything is regulated by the investigator. So you start with the target population, you take consent of the population, and then you select the study population. So we call it as sample population. Then you have a inclusion exclusion criteria, a strict one, where you will decide that who will be a participant population and whom you need to exclude, that okay, they don't fit into the eligibility criteria. Those who are included, they get divided into groups after randomization, and then you administer the intervention, and at the end you compare the outcomes. So this becomes a complete setup of a RCT, and this is a gold standard. But most of the times, in most of the setups, this sometimes gets very difficult to approach, and that's why we go with other experimental design, and at the end we go for RCT, because here lots of inclusion exclusion criteria, eligibility patterns, control environment, randomization comes in the picture. Now, why we need to do a randomization in RCT? I have already mentioned that it gives equal chance to the both the participants to be selected into the new treatment or standard of care equally. So they have better chance. It also reduces the bias. And in terms of randomization, it gives best way to prove the effectiveness, because now you are not dividing the population. They are getting divided based on the randomized sequence. So the control of the investigator is not there. Automatically the bias is reduced, and the sample which you have taken out gets equally distributed among the study group and the trial group. So then again, there is a blinding technique, and you must have heard double blind, single blind, triple blind. Now, blinding is also done for the benefit of the quality of trial. It is really troublesome to conduct, but it increases the validity of the trial. It gives the higher evidence in the trial, because in single blinding, the participants are not knowing what they are getting, whether it is a placebo or a drug. In double blinding, the investigator is also not aware that whether the trial group is receiving A drug or B drug. And in triple blinding, even the analytics or the statistical experts, they are also not aware that which group receive which drug. So everything goes unbiased and in a transparent mode of operations, and that's why it becomes more credible. And they also eliminate all types of biases. So the participatory bias, selection bias, calculation biases, everything is getting reduced. Now, these two, the slide is not that clear, but these two things are very important, cause and effect. In clinical setup, in experimental trial, we undertake cause and effect relationship. So cause, if cause can be manipulated, like suppose smoking, it can be manipulated, and that is an independent variable because it has direct impact on the effect. Effect, say cancer, is measurable and it is dependent on the cause. Okay. Similarly, treatment can be an independent variable. Treatment can be manipulated. Treatment can cause an effect on health promotion, on curation of the disease and everything. So treatment is independent variable and disease becomes dependent variable. Okay, so try to understand these two factors, very important factors. So if you are identifying risk factors, then it becomes cause as a risk factor, like smoking, junk food, sedentary lifestyle. They're all independent variables. Effect will be obesity, cardiovascular problems, and say hypertension. Similarly, if you are using a drug on hypertension, that becomes a cause. That drug can be manipulated, and it's an independent variable. I hope I'm clear into these two cases. Now, in clinical trials, particularly RCTs, there are phases, and you all are aware in terms of COVID, every citizen is aware about the course of clinical trial. And phase 1 trials are generally important for safety and acceptability. That a new molecule comes into the lab, it gets discovered, and now we need to prove that that molecule is safe to be used in healthy individuals. So just highlight the part healthy individuals. Here the patients are not there. They are perfectly all right, but we want to see whether healthy individuals can accept the drug or not, whether it is safe for healthy individuals or not. And that's why phase 1 trials are conducted. Phase 2 trials are for long-term safety, for finalizing the dose and schedule of the drug, and also early indications of efficacy. Now, why we are saying early indication? Because the dosage is yet to be fixed. And that's why till we achieve the appropriate dose regime, we cannot say really about efficacy, but we can get some of the key glimpses about how effective that drug could be. And here the participant number goes up 100 to 500, low risk, but here the patients are considered, not healthy individuals. Phase 3 is about effectiveness, how the drug is effective in managing the treatment. Again, the number of patients go up 1,000 and more, but the risk is also higher because now the drug is in the full dosage format. And phase 4 are overall for the post-marketing trials and community-based. So why community-based trials are important? Because when we select samples, they are selected from a particular targeted population. But when the community, when the drug goes into the market, all these control environments are not there, and the people are consuming that drug in the natural setting. And that input is very important for us, that how that drug is acting in the community. There are illustrations when post-marketing studies showed that this drug is causing a problem and then they were withdrawn from the standard of care. For example, in COVID also we know initially plasma therapies were administered. Initially they recommended that therapy. Some new drugs were recommended and then they were withdrawn because post-marketing studies shown that they are very much toxic. So even in this particular therapeutic trial, suppose I want to study a new drug regime for HIV patients, I will identify HIV patient, then define inclusion-exclusion criteria. If I want to put it in the RCT model, then I randomize those patients into two. One receives the new drug, other receive the standard of care. Then I will follow them up with the clinical parameters which I set up, like a viral load or CD4 count. Periodical follow-up will be there, and at the end I will compare the two outcomes, and then I can say something about my new regime because it also involves the comparison with the gold standard. And that is why RCTs are considered as gold standard for launching the new drug. Now, most of the clinical trials, and this is very important point now, most of the clinical trials or experimental trials need to get registered on Clinical Trial Registry of India. And it is now almost for every publication they ask for it. University is still not mentioning it as a mandate, but make sure that you are doing it for your research project. Now, what is the benefit of doing a CTRI registration? First is, CTRI is a government portal, Indian government portal, which is visible globally. So anyone who wants to undertake a trial, they will see what is happening in India, who is conducting that trial, what is the current status of trial, everything will be visible on the portal. So the visibility of your trial goes on the global platform, not only Indian, but it is a government platform, so gives more credibility for your research. Second is, after the research is complete, when you want to publish your trial, most of the publishers are nowadays asking for CTRI registration. Okay, because CTRI ask for ethical certificate, ethical clearances. So automatically publisher is making sure that you are following the standard protocols, you are already having an ethical clearance, and then you are approaching CTRI. That means everything is already pre-screened and ready to publish. So there are no conflicts involved into this, and they are ready to publish. So that's why you already also get a credit for the CTRI number if you are planning for a publication. And third, most important thing, CTRI is for an ongoing trial. Okay. So what happens, most of the students ask me this question that वैसे भी तो PubMed पे दिख ही रहे हैं ना सारे trials after publication. So what is happening in CTRI? PubMed पे या किसी भी database पे trial तब आती है जब वो complete होती है, when it is published. In CTRI, it is an ongoing trial which is getting a publication, or you can say a platform where it is visible. So if a patient is looking for a trial and he wants to participate in that trial, even patient can see the CTRI website. and they can see where the trial is happening. If some patient is interested for a, say, a brain cancer treatment happening in, say, Maharashtra, and they really want to know if there is some other option available in brain cancer management, they will visit CTRI, and patients are more aware than us, minded, because patients are very much active into this. The moment they Google it out, what is the new treatment, first 10 pages में एक तो CTRI का option होगा, because these are the current trials. People try, Google पे try करते हैं कि नया trial कौन सा चल रहा है, ब्रेन कैंसर पे क्या नया मॉडलिटीज है, या इवन इन various dental implants people are trying nowadays, they are searching. So if there is a trial of their interest, they might contact you and participate. So automatically आपको patients के लिए भी एक display हो रहा है कि okay, this trial is being planned and patients can also take participation. Not only in terms of a layman, but a scientific community can also approach you. Okay, so in CTRI website, there is an option of scientific query and public query. So if you are putting your name under scientific query, you will be getting a contact from similar investigators, those who are working in same area or same drug modalities or same treatment. They can contact you for future collaborations. So that is also an advantage. And public queries are from patients or those laymen who are interested into your region. And now public queries could be from sponsors also. So, those who are interested in your research, those who are planning for some kind of a new modalities or therapies, or planning a machine on similar nature. So if you're working on a machine-based kind of a thing, in dentistry, there are lots of bioengineering happening. So bioengineering kind of a thing, layman like an engineer can also search a trial registry to see what is happening in AI, what is happening in engineering model, what is happening in bioengineering setup. So they can also approach you for a collaboration or funding or sponsorship. So lots of avenues are getting opened up. So do not underestimate that, okay, CTRI is just a trial registry. So don't wait that university will make it mandatory. Go for it and get listed on that. So advantages of RCT. And now, yes, and on CTRI, people also ask me one question, that if my participants are healthy individuals, why should I go for a clinical trial registry? They are not patients. But if it is a biomedical research which involves participants or patients, that needs to be listed on the CTRI, unless CTRI rejects it, that okay, it is exempted from our nature of or our scope. Write to CTRI that we are planning on so and so, try to enroll your trial. If it is not required, they will mention that it is not needed to be listed, but go for it. Okay. The basic advantages of RCT is simple. We all know that we are trying to minimize the biases. We are controlling the confounding factors. We are also having blinding and randomization in place, and also gives more evidence. So maintain advantages of cohort studies. So cohort ke aage wala stage jo hai, that is RCT. Major disadvantage in RCT is it is very expensive and complex. Now, like I mentioned, even if you want to try a 30 patient trial in a RCT model, it may become sometimes difficult to undertake it because there are dropouts involved, there are withdrawals happening, consent procedure is complex, even the documentation process is very critical. So all these things, ethical challenges are important. If your drug has some adverse drug reactions or side effects, you need to again report back to ethical committee, and then this process is time consuming. So for a student who is planning for a 2-year plan of research, generally we are having a 3 years post-graduation. But if you calculate the actual period where they are contributing to the research is hardly 12 to 13 months. Okay, because they are having so many other curricular activities. They need to conduct their postings, clinics, lectures, exams are there. So all these timelines we need to consider, and then we need to see what kind of RCT model is feasible for the student. But yes, if you are going for a funding opportunity, if you are trying to have a collaborative research, go ahead and plan for a RCT. We all are aware about IRB. It is Internal Review Board. Some colleges have IRB as well as IEC. Okay, so now university is also asking for BORS. So your institute must be having a BORS committee where Board of Research Studies is established, and they are conducting the whole activities as IRB. So they are helping the students to develop research protocols. They are also trying to work around the content of the trial. Okay, so IRB is very important. And now if this is the question, IRB, which option you will select? The Internal Review Board is responsible for what? Are they involved in developing of the research protocol? Do they help in actually typing, or they provide the protocol? Are they helping us to have an informed consent? Are they just reviewing the protocol? Are they monitoring the patients? Are they collecting the data? Which part is focused for IRB? So option will be 3, where IRB is totally reviewing the protocol for ethical consideration. Rest of the things need to be done by the investigator. Okay, so IRB is not bothered about writing of the protocol or monitoring the patient directly. They rely on your reports, but you need to give timely reports to the IRB. Particularly if you are having some adverse drug reactions or side effects, you need to write it back to them and then have a ethical clearance. Okay, so this is right now. I'll just stop for a moment. We will break for group activity, and what we do is I have discussed with you about so many research designs. So what we'll do is every group will try to identify their research design which fits into the experimental nature. Okay, any modalities they can select, and then we'll discuss it out and we'll come back to this quiz. Okay.
Yes, madam.
So let me know if anybody has any questions till now, so we can break for the group activity.
Madam, one question is there. Madam, this Solomon factorial design you told. In that post-treatment we can do, but when we do the post-treatment analysis without pretest, how to compare this with statistically? Baseline data is not there, no. Directly I'm having only post-treatment data. Then how to compare this with how it is, whether it is aggravated the condition, whether it is maintained like that, or whether it is improved. Exactly, without baseline data, how to exactly come to a conclusion? That part little bit we can,
Solomon group design is having all the 4 groups. Okay, so in clinical setup also there are groups with pre-test. 2 groups are there with pre-test. Okay, so pre-test groups are having a treatment, and then they are getting post-test assessment. Similarly, for other 2 groups, only pre-test is kept. They are giving, one group will be getting a treatment, one group will not get a treatment, and then the post-test will be compared. So when you compare the post-test, all the post-tests will be compared together. So suppose outcome 1 will be from group 1. So O1, O2, O3, O4 will be compared. And for pre-test, only O1 and O3 will be compared, where the pre-test is getting captured. So Solomon group designs gives us more advantage in assessing the cases where pre-test is not captured, but you can see the impact on the post-test in terms of clinical setup, in terms of their quality of life or the pain management. So what is happening in that, we are getting more data sets from all the 4 groups. And that's why I mentioned that when we are able to capture pretest, it is generally in the clinical setup. But in the community setup, we are not able to capture all the pretest related findings. And there it is very much helpful. For example, when we say that, okay, a particular salt water gargles are helpful for flu. So salt water gargles, when you administer in the clinical setup, you have a pretest in hand that, okay, patient was having sore throat or what other complaints. But in a community setup, anyone at any point of time, if they have those gargles, they will have some kind of the impact, and that we are going to capture. Okay, so it is used for generally not only in terms of the drug, but you can imagine a therapeutic regime, or maybe a counseling, a social impact related interventions, or some interventions which are related to the you can say psychological aspect of the patient. So even if the pre-tests are not available, these are very much important to note the overall post-test of all the 4 groups involved. Okay, and there are so many articles in dentistry also. I'll try to find out one design and I'll let you know. But I hope I'm clear with this. I'll just find out one article in the, I was having that, but
this community-based trial post-test data we will be having, but in clinical trial we will be having pre-test data. So can we compare that pre-test data with this post-test data? So outcome variable is same.
No. Pre-test to post-test will be compared only when pre-test is captured.
But in community we are not capturing now, because directly we are having
the
post.
We are not focused on pre-test. Yeah. We will be only comparing on the post-test. That's why I said no, O2, O1, O2, O3, O4. These 4 outcomes will be compared. Not
with
like
only O and O2. So O and O2 will be compared with O and O2, O3, O4.
No, right? No. Total O1, O2, O3, O4 will be compared. Total.
With O and O2?
No, separately.
Okay.
Separately. And
statistically.
And if you want to go with the pre-test post-test model, then O1 pre-test and O1
post-test. That is clear. O1 pre-post, O2, O2. That is fine.
Yes.
Only the doubt was only with respect to community trials. Directly, as we are having only post trials, post-test data will be there. So
no. That is only will be compared for the post-test.
Okay.
Only all the post-tests will be
post-test will be compared at a time.
Yeah. Okay. See, suppose I am having a community training. Okay. I am undertaking one training related to, say, dental hygiene. Now, if I am undertaking that training in a clinical setup, I can have pre-test data.
Yes.
पहले उसका understanding क्या था? 10 में से कितने marks मिले? Right? And then I administer the training. Training के बाद में उनको dental hygiene के बारे में क्या समझा? अभी अगर if you are undertaking same training in the community setup, तो आपके पास pre-test data हर किसी का नहीं होगा. But definitely the post-test data जो आएगा,
Madam, sorry to interrupt. Before that only, before we intervene that only, directly first we can calculate we can take the baseline data. No, before giving the one instruction or one module which you want to give, first collect that information, then you intervene with your whatever module you want to improve, then follow up it up, then do the post test, so that we will be having that. We'll be having the data of the baseline there in community based also.
Sometimes, sir, there are conditions when we cannot capture the pre-test. Okay. And that is why Solomon 4 group design is selected. Most important, when you are having a feasibility of capturing the pre-test data, why you will go for Solomon group design? You can have a pre-test post-test design, just a 2 experimental design, right? But when the group size is more, the feasibility is not there to capture pre-test, you go for a Solomon 4 group design. Okay, in the control setup, this was the outcome. But in terms of a community setup, even if we are not having a pre-test data, we are having
directly go for post-test.
Yes. Outcome. And that's why this design is using the benefits of pre-test post-test design also.
Yes, yes,
And
yes.
also the only post-test design.
Post-test.
And that's why exposure related outcomes are captured in this, and that's why people select this design, that they need to check what is happening on large scale data. So and in dentistry we can say that, okay, suppose we are undertaking a training or a mass toothbrushing exercise for schools. You try to recommend that, okay, there should be 5,000 students from the school need to have this exercise for 7 days. Now you cannot assess those 5,000 people on the dental hygiene, but definitely whatever you get on the post-test, that can be having some kind of an impact, that, okay, this is the impact of toothbrushing for 7 days at school, because it was under observation and it was done continuously for 7 days. And that is also very important outcome. And this really helps in trying to have a understanding of community involvement. And then maybe further you can decide a pre-test post-test design. But it improves the validity of the design, that, okay, this can be done. This can be done.
Fine.
Any other question? Any other question? Or we can break for the group activity. How much time we have, sir?
We have, madam. We can now start with group activity, madam.
Okay. So how we can either we can have.
We are divided into 5 groups. Five groups. We are divided into 5 groups. Now you told initially we will give the modules to each group so that they will let them identify what type of design.
Okay.
That's what you are. Yeah.
Okay. Okay, so students here can, okay, so everybody is here only. So what we can do is, group 1, if they are ready, they can discuss their idea.
Group 1, who's group 1? Group 1 Yeah. All PG students are group 1, madam.
Okay. And who is group 2?
Group 2 are all group 2, group 3, group 4 are faculties.
Okay.
Different. We are divided into different groups.
Okay.
So group 1 is postgraduates.
Group 1 is postgraduates. Okay.
Yeah.
So if they are ready, we can go ahead with them.
Madam, ready, madam.
Okay. Yeah. So group 1, please share your idea, what exactly experimental design you are trying to undertake. Anyone, any representative from the group can talk.
So yours is group 3. Group 1 is postgraduate students.
Have you divided them into breakout rooms, sir? Because I can't see all the breakout rooms. I can see 16 participants here.
Madam, breakouts, we have done the breakouts.
But I can't see the breakout rooms.
Madam is not able to see. Madam, you are co-host, you can see, I feel, because we have created the breakouts. And we are divided into 5 groups. Group 1 is postgraduate students. You people involved, no? You are able to see? Yeah, please, you start discussing with madam.
No, I can't see the breakout room, sir.
Madam is unable to see the breakout.
There is no option of breakout room here.
Madam is not able to. 1 second, madam. Just give me a second.
Okay.
Hello, ma'am. Ma'am, you have to. Can you see the option more down?
No.
Where your option is share screen and all you have over there. Next, there will be an option called more. Can you see that?
Madam, in lower side. Lower arm.
Yeah.
Next to that.
Ma'am, on click on more, you can see breakout rooms. So there are 5 breakout rooms. You can join any one room, ma'am. You have to join one room. That's
No, I can't see more option. Generally, I have this access to the breakout wala option आता है ना, वो नहीं आता.
ma'am. वो ma'am more में आएगा आपका अगर.
नहीं, the ask all to unmute, mute participants entry वाला वो option है. I'm not
No, ma'am.
having that.
नीचे जब वो आपका mute, start video, security, participants दोस्तों option है ना?
नहीं, वहाँ पे नहीं आ रहा है.
मैम वहाँ पे more बोल के option दिख रहा है आपको?
नहीं.
More भी नहीं दिख रहा आपको? Reaction,
More भी
apps,
नहीं दिख रहा है.
breakout room.
It is just showing mute, stop video, security, participants, chat, share screen, record, and reaction.
Ma'am, do one thing. If your participants in the side of the thing is open, just close that so that all options can open down.
Fluorescent in mouthwash on dental peels.
Okay. And what will be the study design?
Ma'am, we'll select a sample population with poor oral hygiene or from different socioeconomic groups. Then we will have a control group where we can give those people pure exuding mouthwash uses regimen. After a period of time, we can assess oral hygiene has been or necessarily the uses of mouthwash in maintaining the oral hygiene.
Okay. So you will have 2 groups only? You will have 2 groups.
Yes, ma'am.
Okay. Then before administrating the intervention of mouthwash, you will capture the readings, right?
Yes.
The current status. Then you will conduct the experiment, and afterwards again you will capture the current status and right?
Yes, ma'am.
Okay. So how you are going to analyze the outcomes? You are going to compare O1 and O2, right?
Yes.
We'll be comparing O1 with O2. Like what was the outcome?
So I'm
Where
not
the
audible. Sorry.
Hello? Am I audible now?
Yes, ma'am.
Dr. Shraddha, you need to put it on mute. There is a sound disturbance. Yeah. Am I audible now? Okay. So suppose you are dividing the groups into two. One is with the mouthwash and other is without mouthwash, right? So no treatment and treatment. There is no comparator mouthwash, no comparator, no control. Just with mouthwash and without mouthwash. That is your comparison. Okay. So but when you want to compare in experimental design, generally we have a comparator. But if there is no exposure to intervention, it becomes true experimental design. Okay. So you are identifying the population, then you are selecting the sample, assigning randomization. Okay. So you will randomize them in group 1 and group 2. Group 1 will receive mouthwash, group 2 will not receive mouthwash, right? So it becomes a true experimental design, pre-test, post-test, randomized design. Okay. And at the end of say 15 days, 1 month of use, you will try to compare the effect or impact of the mouthwash. Correct? So is it clear to everyone?
Yes.
When you use a comparator mouthwash, suppose mouthwash A and mouthwash B, it becomes RCT, randomized controlled trial. Right? Because suppose chlorhexidine becomes standard of care, the gold standard. And if your new drug is equivalent or more effective than chlorhexidine, then it becomes trial group. So standard of care is being compared with the trial group, and at the end you are going to compare both the outcomes. So that is a RCT design. Okay. But in your case, you are saying that other group will not receive any kind of mouthwash. So it is a true experimental design. Am I clear? Okay. So how you are going to plan the randomization into two groups? कैसे करोगे आप randomization? How you are planning for randomization?
And by multi-stage sampling technique, then we'll select an area according to which we can up the sample from that area, and then we will segregate two groups. One we will provide the chlorhexidine, other we won't provide the chlorhexidine, and then we'll frame a time phrase between, and after the time phrase we'll check the results, compare the results basically.
Okay. Okay. So how long you are planning to use chlorhexidine? How long you are going to use chlorhexidine?
15 days.
Okay. So to highlight that it will be only for 15 days, we need to have a literature backup. Why 15 days? Is it a lucky number? No, right? So how you derive that it should be used at least for 15 days, तब जाके कुछ effect मिलेगा. Otherwise somebody will say 7 days use कर लो, right? So to confirm कि 15 days तो minimum use करेंगे तभी तो कुछ effect दिखेगा, और maximum should be 2 months continuously. Otherwise उसके बाद फिर enamel में कुछ problem होगा, ज़्यादा deterioration होगा, ऐसे कुछ अगर studies है तो you need to also mention that. that we have identified 1 month or 15 days based on this literature of minimum and maximum duration of using so and so drug. कितना safe है, कितना effective होगा, उसके basis पे you can give illustration. Randomization you correctly say, okay? और बाद में फिर उसको आप दोनों groups को compare करने वाले हो, right? And there is one more comparison possible. कैसे? सिंगल ग्रुप कंपैरिजन भी पॉसिबल होगा कि जिन्होंने माउथ वॉश यूज किया उनका प्री टेस्ट और उन्हीं का पोस्ट टेस्ट कंपेयर करना है ना. तो आपको और एक कंपैरेटर मिल जाता है कि एक ही इंडिविजुअल है जिसने पहले माउथ वॉश यूज नहीं किया था, पर उसका कुछ एक स्टैंडर्ड, कुछ तो भी हेल्थ डेंटल स्टैंडर्ड होगा, डेंटल स्टेटस होगा, और उसका स्टेटस इंप्रूव हुआ है माउथ वॉश के बाद या नहीं, दैट ऑल्सो विल कम टू नो. तो सिंगल ग्रुप कंपैरिजन भी पॉसिबल है एंड ग्रुप ए एंड ग्रुप बी का कंपैरिजन भी पॉसिबल है. ओके, सो ग्रुप ए में जिन्होंने माउथ वॉश यूज किया उनमें क्या डिफरेंस लगा और जिन्होंने नहीं यूज किया उनमें क्या डिफरेंस है, दोनों पॉसिबल होता है ट्रू एक्सपेरिमेंट में. ठीक है, किसी को कुछ क्वेरीज हो तो आप पूछ सकते हो.
Ma'am, we need to have a specific age group, or we can just give it to everyone. Like we need to have a specific age group, right?
जनरली ऐसा होता है ना, जब आप एक्सपेरिमेंट कर रहे हो तो यू नीड टू डिफाइन द एक्सपेरिमेंट वेरी नाइसली. जैसे हमने बोला था ना, रिप्रोड्यूसिबल होना चाहिए हर एक एक्सपेरिमेंट, कि कल को जाकर अगर किसी और स्टूडेंट ने प्लान किया सिमिलर स्टेटस पे सिमिलर माउथ वॉश का डिजाइन लेकर उसको करना है, तो दे नीड टू हैव अ कंप्लीट नेचर ऑफ द एक्सपेरिमेंट, कि आपने कौन से एज ग्रुप का किया था, कितने पेशेंट्स लिए थे, उनकी कोई कोमॉर्बिडिटीज थे या नहीं थे, कुछ डेंटल उनकी हिस्ट्री थी या नहीं थी. सो यू कैन डिसाइड कि आपको लेना है सारे एज ग्रुप्स के लोग, कि जैसे 18 to 70 अगर आपका एज ग्रुप है तो 40 के बाद वाले सारे डेंटल प्रॉब्लम्स भी उसमें ऐड हो जाएंगे ना, तो कंफाउंडिंग फैक्टर भी ऐड होंगे. तो why we want to identify eligibility criteria, because हमें वो कंफाउंडिंग फैक्टर कम करने, कॉज एंड इफेक्ट है ना. इंडिपेंडेंट फैक्टर्स जो है आपको उसी एक ही इंडिपेंडेंट फैक्टर का इफेक्ट देखना है, नहीं तो क्या होगा कि जो ऑलरेडी जिनके बहुत सारे डेंटल प्रॉब्लम्स है उसमें आप माउथ वॉश यूज करोगे तो आपको शायद इतना इम्पैक्ट आप स्टडी नहीं कर पाओगे जितना आपने प्लान किया था. सो आइडियल वे इज यू आइडेंटिफाई एवरीथिंग, एज ग्रुप डिसाइड कर लो, फिर आप अगर आपके इसमें कुछ डिसीज कंडीशन कॉज बन के आ सकती है डेंटल इश्यूज में, तो यू कैन ऑल्सो से कि इन्फेक्शियस कंडीशन हम अवॉइड करेंगे. जहाँ पे क्लोरहेक्सिडिन कॉन्ट्राइंडिकेटेड है यू कैन ऑल्सो से दैट दोज पीपल विल नॉट इंक्लूड. So everything will be properly planned so that anybody else can use the similar design and check for the reproducibility of your claim. आपने अगर बोला है क्लोरहेक्सिडिन से किसी को भी डेंटल केरीज नहीं होंगी, तो वो क्लेम उसको फिर से जस्टिफाई करने के लिए he or she needs to reproduce the experiment. And that's why हम एक्सपेरिमेंट कैसे कर रहे हैं ये सारा डिटेलिंग करना बहुत जरूरी है. ओके, और कोई क्वेरीज है?
How do we observe to the control group where we are giving fluorescent mouthwash? How can we have a check on them that they are using properly, they are following all the
whether they are using it or not? एक तो पहला जो सबसे श्योर शॉट मेथड है वो है डायरेक्ट ऑब्जर्वेशन, है ना, कि आपके सामने उसको 7 दिन बुलाओ 10 दिन बुलाओ और आपको बोलो कि इतने टाइम के लिए माउथ वॉश करना है, और यू गिव अ पेशेंट इंफॉर्मेशन शीट दैट बीइंग इन दिस ट्रायल यू हैव टू मैंडेटरीली डू सो एंड सो थिंग्स, 1 2 3 4 स्टेप्स में ही करना है, कि पहले आपका ब्रशिंग होना चाहिए, फिर क्लोरहेक्सिडिन का इतने ही क्वांटिटी में आप लो, इसको डाइल्यूट करना है नहीं करना है, कितने देर के लिए गार्गलिंग करना जरूरी है मिनिमम, एवरीथिंग नीड्स टू बी मेंशन्ड एंड देन गिव इट टू पेशेंट. और उसको आप क्वांटिटी को भी जस्टिफाई कर सकते हो कि आपने कितने बॉटल्स दी थी, कितने ml दिया था, और पेशेंट ने कितना कंज्यूम किया है, कितना बचा हुआ है. और आप पेशेंट को बिना बताए ये बोल सकते हो कि आपका जितना भी ड्रग बचेगा वो हमें वापस लाके दीजिए। तो आपको एक अंदाजा हो जाता है, अगर वो पूरी की पूरी बॉटल वैसी की वैसी दिख रही है आपको, या हार्डली 1/4 खत्म हुई है, तो यू नो कि इट इज नॉट बीइंग यूटिलाइज्ड प्रॉपरली, जो डोज हमने बोला था। तो एक अंदाजा हो जाता है कि पेशेंट कर रहा था या नहीं कर रहा था। ठीक है, डन। So you can write a small project on this true experiment design, and then you can submit it to the sir. फिर वो भी आपको थोड़ा सा बताएंगे, and if you have still any queries, you can send that project to me also. Okay. Okay. Thank you.
Thank you, ma'am.
Thank you.
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Yes. So yes, tell me if there are any queries, you can ask, or if you are working on some design, we can discuss that.
Yes, ma'am. Like suppose we develop a module, ma'am, and then if I want to check the efficacy with the person who has got and who hasn't got. Like suppose I implement a module from first year, I introduce something new. So can I do something? Can I do a comparison with the final year who or third year or some person whom I have not implemented that module? Means how do we check the efficacy, ma'am?
Is it a teaching module or a treatment module?
A teaching module, ma'am.
Teaching module, okay. So you want to see who is having access to that module, or they have used it?
Yes, ma'am. Like suppose we implemented, suppose I implemented from 2022 in the batch in 2022. So can I check the efficacy? How do I check the efficacy? In my mind, it was something like the people who have not been imparted. That means suppose 2021 I didn't impart it.
Comparing
So,
the result.
yeah, can something like this be done, ma'am?
Okay, so see, when you are having a comparator who have not received the module, your design fits into the true experiment nature. Okay.
Okay, ma'am.
Like one group is receiving a module and other group is not receiving the module, and then you are comparing them.
Yes, ma'am.
But in both the groups, you need to have some baseline measurements. What was their understanding about the topic? Maybe you can have a pretest of say 10 MCQs or 15 MCQs. You can know the understanding and then administer the module in one group. Second group goes with the flow of regular curricular activities. And at the end of the module, you will again have a baseline measurement about the same test, post-test. And then you'll see that, okay, how many are having a good understanding about that particular topic with a new module. And that becomes a true experiment, because in true experiment, the comparator does not receive the intervention. But
yes, ma'am. But then there is this thing is also there. No, they say that we cannot deprive any educational thing.
Yeah. So see, when that comes, if the module is feasible to administer in one academic year, twice, you have enough time for that. Sometimes what happens, the module length could be 1 month, could be 2 months. So if your module is a short module, it can be administered in 1 week or so. You can have a crossover design. Crossover becomes easy. Then same goes up at the end. You will change the groups and again teach some other method, other topic with the same module, and then test it. But you know what happens in the teaching experimental setup? If both the groups are interacting with each other, the whole effect goes down the drain.
That's true, ma'am.
Because group 1 can talk to group 2, अरे हमने इसको इस तरह से सीखा है, ये टेस्ट आ रही है, इसको ऐसे ऐसे आपको मार्क करना है, तो खत्म हो जाता है, आपका पूरा एक्सपेरिमेंट ही खत्म हो जाता है.
Or many times they take, we have to take two topics of similar difficulty level and then do a crossover, something of that sort.
So for crossover, you need to parallelly conduct that experiment. You know, कि एक classroom में आपका एक मॉड्यूल पे सिखाना हो रहा है, दूसरे क्लासरूम में सेम टाइम पे नॉर्मल कोर्स से सिखाना चल रहा है. दोनों इंटरेक्ट नहीं करेंगे बिल्कुल भी पार्टिसिपेंट्स. एक सेक्शन, एक लेक्चर होने के बाद आप दोनों क्लासरूम को एक्सचेंज करोगे एंड यू विल टीच द सेम टॉपिक अगेन. और फिर बच्चों को पूछोगे कि हाउ वाज द डिफरेंस इन टर्म्स ऑफ अंडरस्टैंडिंग, एप्लीकेशंस, आपका पोस्ट टेस्ट, वो सारा पैरामीटर फिर आ जाएगा. पर क्रॉसओवर करना हो तो दैट आल्सो नीड टू बी कंडक्टेड एट द सेम टाइम. Then you need to make sure that आपके पास दो फैकल्टीज है क्या कि जो वो मॉड्यूल सक्सेसफुली एडमिनिस्टर कर सकते हैं दो क्लासरूम में पैरेलली. Same assessment method needs to be used. Same parameters needs to be assessed in terms of baseline measurement.
Yes, ma'am.
वो अगर आप constant कर सकते हो तो crossover is also a good choice. Otherwise, you can have a true experimental design. Anyone else, if they have having any queries, or if you already are working with some project, we can discuss that. I hope the experimental designs are clear to all, because there are so many permutation combinations. Pre-test, post-test is the commonest one, single group. Double group में आप जाओगे, pre-test, post-test करोगे, तो वो true experiment बन जाता है. एंड अगर दोनों ग्रुप में इंटरवेंशन है, एक में स्टैंडर्ड ऑफ केयर है, एक में आपका ट्रायल इंटरवेंशन है, दोनों का प्री टेस्ट पोस्ट टेस्ट हो रहा है, देन इट बिकम्स आरसीटी. क्योंकि आरसीटी में द मैंडेट इज अबाउट रैंडमाइजेशन, देयर इज अ मैंडेट ऑफ इंक्लूजन एक्सक्लूजन क्राइटेरिया, एंड नाउअडेज वी आर स्टिकिंग आवर प्रोटोकॉल टू कंसॉर्ट गाइडलाइंस. So we have to follow Consort 2010, and then you need to again say the withdrawals kitne the, dropouts kitne the, what was the parameter of assessment, everything, and then you can go ahead with the RCT. Okay.
Little sometimes difficulty to understand these designs, man. So is it like the more we do, the more we understand? Because you know, something of that sort means I feel it's very volatile.
No, actually, see, the simplest way to deal with what design needs to be selected is think about the end in mind. Okay, that what exactly you want to prove. आपको अगर ये प्रूव करना है कि स्टैंडर्ड ऑफ केयर से बेटर है, देन यू हैव टू गो विथ आरसीटी. आपको जस्ट इतना देखना है कि स्टैंडर्ड ऑफ केयर के कंपैरिजन में आपका ड्रग कहाँ स्टैंड हो रहा है, गो विथ एक्सपेरिमेंटल डिजाइन. आपको बस इतना देखना है कि आपके पास कंपैरेटर नहीं है, बट सेम इंडिविजुअल का ही आपको प्री टेस्ट पोस्ट टेस्ट करना है, तो सिंगल ग्रुप प्री टेस्ट पोस्ट टेस्ट डिजाइन में जाइए. सो ट्राई टू आइडेंटिफाई द एंड कि एग्जैक्टली आपका जो हाइपोथेसिस है, व्हाट विल बी द बेस्ट पॉसिबल design where I can clarify my hypothesis in a better light. अगर वो आप आइडेंटिफाई कर लेते हो तो आपको आइडेंटिफाई करने में ज्यादा दिक्कत नहीं होगी, because what happens then, all these aspects are clear. Do you want to have an epidemiological trial where you just want to describe the event? तो आप एक्सपेरिमेंटल सेटअप में जाओगे ही नहीं ना, you will select a descriptive model. Do you really want to work in the experimental setup with the intervention in hand? तो आपका experimental nature आ जाता है ट्रायल का. अगर आप if you want to compare the results, तो आपका definitely analytical में जाता है. या आपको अगर मतलब descriptive में अगर compare करना है तो. अगर experimental में compare करना है तो आपको true experimental में जा सकते हैं. You can go for RCT, you can have comparator designs. तो वो अलग-अलग designs बढ़ते जाएंगे. And nowadays people are also focusing on case series. तो कभी-कभी ऐसा होता है कि we are not sure about the design. तो just try to have 10 or 15 cases in hand, elaborate all the findings, outcome आप decide करिए कि आपने क्या-क्या interventions दिए थे, and then try to identify कि okay, which design will be suitable to test my hypothesis. अगर आपको hypothesis develop करना है नया, तो you will not do experimental design. You will go for only observational trials. अगर आपको hypothesis test करना है, तब आप experimental design जाओगे. This is the difference. तो कुछ basic questions if you ask to your own hypothesis, you will get to know the design.
But ma'am, like what we learned today was like when we do these observational study, we come to a hypothesis. But hypothesis is if you have to test it, then observational studies are not the means to do it.
Yeah.
So, but then ma'am, ऐसे hypothesis कैसे आता है? Like, do we just like see हम मतलब that's what like how do we land at all this like?
हाँ नहीं सी अगर हाइपोथेसिस आता है मतलब वो आपको डेवलप हो जाता है अपने आप इन टर्म्स ऑफ द आउटकम ऑफ द सर्वे. फॉर एग्जाम्पल मैं एकदम सिंपल देती हूँ बिकॉज आई कैन नॉट गिव टेक्निकल इलस्ट्रेशंस इन डेंटिस्ट्री, बट एक सिंपल एग्जाम्पल है दैट हाउ मेनी डेंटिस्ट नाउअडेज यूज हर्बल रेमेडीज. ओके, अगर मेरा ये सर्वे है, ठीक है, मेरा क्वेश्चन ही ऐसा है कि मुझे बस सर्वे करना है. I don't want to test here any hypothesis, right? मेरा hypothesis ही नहीं है कुछ, because I am not having two variables in hand. Independent and dependent variable तो चाहिए होगा ना hypothesis decide करने के लिए. तो अभी मेरे पास कुछ भी नहीं है डेटा, तो I will conduct a survey. 100 dentist का इंटरव्यू लेने के बाद अगर मुझे समझ में आता है that 100 out of 100 are using some or other way of the herbs into their practice, including the clove oil or triphala or other aspect of it. So I will have a hypothesis now that natural remedies are being used in dentistry, and now I want to see that how many dentists are having the experimental setup, experimental trials on that. फिर से एक सर्वे आएगा. अभी मेरा जो सर्वे था उसमें मुझे बस एक नंबर मिला कि कितने लोग यूज कर रहे हैं. जितने लोग यूज कर रहे थे उनका मैंने फिर से सर्वे किया कि ओके कौन सा ड्रग यूज कर रहे हैं. इफ आई वांट टू सिलेक्ट, नाउ माय क्वेश्चन गोज टू व्हाई अ पर्टिकुलर ड्रग इज बीइंग यूज्ड सो मेनी टाइम्स. क्लो ऑयल क्यों यूज कर रहे हैं सब लोग? देन आई नीड अ एक्सपेरिमेंटल डिजाइन बिकॉज आई वांट टू नाउ टेस्ट द एफिकेसी ऑफ क्लो ऑयल इन डेंटिस्ट्री. कोई भी एक कंडीशन ले सकते हो आप कि इसी में हम क्लो ऑयल क्यों यूज कर रहे हैं, एंड देन यू नीड अ एक्सपेरिमेंटल डिजाइन. तो हाइपोथेसिस बिल्टअप अपने आप होता जाता है बेस्ड ऑन द आउटकम ऑफ योर सर्वे, एंड सर्वे से यू विल गेट वेरिएबल्स इन हैंड. वेरिएबल्स मिलने के बाद आपको ये देखना होता है कि वेरिएबल 1 कॉज है या इफेक्ट है. अगर वो कॉज है तो वो इंडिपेंडेंट वेरिएबल है. तो इंडिपेंडेंट वेरिएबल कहाँ पे इफेक्ट कर रहा है? इज इट इम्प्रूविंग द हेल्थ कंडीशन? इज इट मॉडिफाइंग द डिसीज आउटलाइन? or we are improving just the current condition of the patient without curing the disease. वो बस एक rehabilitative करके यूज कर रहे हैं. तो अब आप आगे जाइए and then you test the hypothesis. अच्छा इसका एफिकेसी मुझे टेस्ट करना है, तो मुझे RCT करना पड़ेगा. So you go step by step. वो जो हमने पिरामिड देखा ना, वो उसी तरह से है कि you have a background information. अरे ये एक ड्रग आया है नया मार्केट में, it is very effective. एक बैकग्राउंड इन्फॉर्मेशन है, no evidence in hand. उस information you just try to collate that information with available literature, थोड़ा सा evidences in the clinical practice. Demand from the patient is also important. Patient demand nowadays that we want safer options, ज़्यादा side effects नहीं चाहिए वगैरह. तो that kind of approach builds up inquiry. Inquiry आएगी तो आप आगे जाके experimental setup design कर सकते हो जितने variables आएंगे आपको हाथ में. तो वो इंडिपेंडेंट एंड डिपेंडेंट वेरिएबल एक बार मिल जाता है, देन यू कैन सेट अप एन एक्सपेरिमेंट. एक्सपेरिमेंटल स्टडी इज नथिंग बट देखना है करके कि ये अगर मैंने मैनिपुलेट कर दिया तो क्या होता है. बस यही है एक्सपेरिमेंटल सेटअप में. अगर मैंने डोज कम कर दिया, डोज ज्यादा कर दिया तो क्या होता है. इफ आई कैन यूज इन कॉम्बिनेशन विद सम अदर ड्रग तो क्या होता है. सो दीज काइंड ऑफ मैनिपुलेशंस आर एक्सपेरिमेंटल डिजाइन्स. ओके, any other queries? Any queries? Okay, thank you.
Thank you, ma'am. Thank you.
Yes, ma'am.
Yeah. So,
Ma'am, good afternoon, ma'am. Can we start?
Yes, yes. Good afternoon. If
Yes.
any design
Yeah.
is working on, you can share that.
Yeah. Ma'am, we have thought of a study of a crossover design.
Okay.
Like we are thinking of therapy in patients with oral lichen planus. And in same patient, we are trying two therapies. So can it be called as a crossover design?
In the same patient, you are, sorry?
Trying two different treatment modalities.
No, that is not a crossover design.
Okay.
Somebody's mic is on. I can't hear properly. Yeah. So see, suppose you are planning, you actually objective is you want to test two modalities, right? Treatment modalities.
Yes.
But in same patient.
Yes.
Okay. Then it is not one single point of time. It will be one after the other. Okay. So suppose
Yes.
one patient first receives treatment A. They undergo treatment A. Okay. For treatment A, they will have pre-test, post-test. Okay. After the
Yes.
treatment, washout time is done. Now it depends if your treatment involves an active drug. So you need to see when that drug is excreting totally out of the body and body is with free of drug now. So you can
Yes,
administer.
ma'am. If you start two treatment modalities at the same time, then what type of study will it be?
So what kind of treatments are there? Can I get more information on?
Yes, I have a topical cream treatment on one side of the oral cavity and a gaseous form of ozone on another side. And we started on the same time. So what it could be?
Okay. So if your objective is to test two treatments in one patient, then go with the comparative design. Don't go for crossover. So,
Yes, ma'am.
and
So
what is the
through
standard?
RCT.
No, what is the
Yes.
standard of care? In your
Standard of care is the topical cream which we are applying.
okay.
That is a gold standard established treatment.
Okay. So you can have a comparative true experimental design where one group receives gold standard, just the tropical ointment,
Yes.
and other group receive local plus your ozone therapy.
Yes, ma'am.
Okay. So
Yes.
then your hypothesis would be to see the cumulative effect of both the modalities in one person at one point of time.
Yes, ma'am.
Okay. And then the second objective could be that you are improving the efficacy with these dual modalities than the standard of care. So it is just not equivalent to standard of care, but it is better than standard of care. That is what you are recommending, right?
Yes.
So maybe then you can have a RCT design also, because there is a proper randomization happening, allotment in terms of inclusion exclusion criteria is done. Then you can administer the intervention. One group receives standard of care, one group receives the complete regime, you can say, and then follow it up and then compare. So a good RCT can be carried out.
Yes, and ma'am, what type of randomization can we think of here? Like simple random allocation method.
There are multiple techniques. Like, see, you can also have a software-based sequencing done. If there are more number of patients, like 50, 100 patients. So, and they must be getting software number from the OPDs, right? So you can say that all odd number will go to group 1, all even number will go to group 2. Or also you can have a lottery method. So these are nothing but simple randomization techniques, but more refined ones. It is not just that you are selecting one after the other. So depending on the odd even, depending on the lottery method, or depending on the this software enabled systems, you can do a randomization. And nowadays, if you put the patient database and put it in the Excel, you can give randomization orders that, okay, I want a particular every third patient, every fifth patient. That way you can do randomization, provided all the listed patients are of the same condition.
Yes, yes.
Yeah.
Yes.
Okay.
Okay, ma'am. Thank you, ma'am.
Okay. Thank you. Okay, so you can share your ideas, or you can have a discussion on the existing trial you are undertaking. Hello, am I audible?
May I audible?
Yes, yes, sir. Tell me.
Okay. So we are doing the experimental design, pre and post technique to check the efficacy of forces applies with class 2 D1 malocclusion with retruded mandible. Means we are giving the appliance that forces to protrude the mandible.
Yeah.
In those cases, we have the mandible is retruded, means mandible is behind.
Right.
So we want to protrude them.
Okay.
So we are giving the appliance because we are dealing with the orthodontics, means So the aim of the study is to check the efficacy of that appliance. That is name is forces appliance in class 2 D1 malocclusion with retruded mandible. That is the aim of the study or aim of the design study. The objective of that to check the efficacy of appliance before and after 6 months of insertion of forces appliance. Means we'll do before P0, how much is the class 2 malocclusion, and after giving that forces appliance, how much it is changed, whether the mandible is growing or whether the length of the mandible is increasing or not, that we are checking.
Okay.
Okay, so the sample size, according to we take the 20 sample size.
Okay.
20 sample size. If there is any attritional rate, so it will be come down almost 12 or 14.
Okay.
Okay, so my inclusion criteria for that, the age group is growing patient. So I need to the growing patient, because in growing patient only the mandible is protruded. So the growing age of the patient is from girls and boys from 11 to 15 year of age, class 2 D1 malocclusion with retruded mandible.
Okay.
Okay, and there is some angle is there. So we keep that as A and B angle. We call it as A and B angle. There are the two angles, the maxilla angle and mandible angle. If the maxilla and mandible ke beech mein, if the difference is more than 4 degree, then only we give that appliance. Or that is the condition where we can give the appliance. So the A and B angle should be more than 4 degree. In that case only we'll give the appliance. Okay.
So, any standard of care available right now for that, or just this instrument is there?
The appliance is there.
Only appliance is right now available. No other treatment.
No, ma'am. Actually, there are the different types of appliance are came. मतलब
Okay.
almost 20 to 25 type of appliance we can give in that case. There's a class 2 proven malocclusion to protrude the mandible. We just want to check the efficacy of that appliance, forces appliance. There are the different type of appliance. There are like forces appliance, Chudo jumper, Jasper jumper. There are the different appliance. We want to check the efficacy of forces appliance.
Okay.
Whether it is going to do the proclination of mandible or not, or how can it is doing, or what is the breakage of that appliances, that we need to check.
Okay.
So that is the efficacy we are checking of the forces appliance.
So if there are no other equipments parallel to this forcep appliance, we can have pre-test post-test. But अगर आपको कोई comparator है आपके पास forcep के जैसा which is in use, then you need to have a comparator in the group.
But we can't do the split mouth technique, na ma'am, because एक side में forces and एक side में we can't.
एक individual will be treated with complete forcep appliance.
In fact, we can do the control group also. मतलब one in one control, or we can do the split mouth also. The split mouth in a 10 patient we give the another appliance, and in 10 patient we'll give the forces, so that can we also compare.
Yeah, दो मॉडल्स हो सकते हैं, जैसे you are identifying pre-test post-test. Pre-test post-test में क्या होता है that we are selecting pre-test post-test because उसमें दूसरा कोई कंट्रोल नहीं है.
Yeah.
है ना? कंट्रोल नहीं है, बट उसमें क्या होता है प्री-टेस्ट पोस्ट-टेस्ट में that same individual becomes his or her own control. कि ये अप्लायंस यूज करने के पहले क्या था स्टेटस और अप्लायंस के बाद क्या स्टेटस है. तो दैट इज आइडियल डिजाइन कि प्री टेस्ट पोस्ट टेस्ट हमने कर लिया, वन ग्रुप टेस्ट हो जाता है, वन ग्रुप डिजाइन है वो. तो इसको हम अभी जो आपने आइडेंटिफाई किया है दैट इज कॉल्ड एज वन ग्रुप प्री टेस्ट पोस्ट टेस्ट डिजाइन. If you want to go with the treatment and no treatment, तो वो भी एक possibility है.
Yes, we can do that.
जैसे कुछ पेशेंट्स ने जिन्होंने ये ऑप्ट आउट किया हुआ है कि we want to go for this technique, that can be in the treatment group. और ऐसे भी कुछ पेशेंट्स हो सकते हैं those who are not willing to do it.
Yes, yes. So we can keep that
comparison भी कर सकते हो.
Yes, yes, definitely we can do that. Means we can keep the control group for those the patient who don't want the treatment.
Yes.
For that appliance. And those the patient where we can put actually that forces appliance. So we can check that. Means yes, we can do that.
So दूसरा जो अभी मैंने बोला आपको, तो उसका नाम होता है post test only with non equivalent groups design.
Post
test only with non equivalent group design. क्योंकि दूसरा जो ग्रुप है दे आर नॉट एट ऑल ऑप्टिंग फॉर द ट्रीटमेंट. और हम उनको कंपेयर जरूर कर रहे हैं. और जैसे आपने अभी जो दूसरा एक बोल रहे थे आप कि आप दूसरा एक टेक्निक यूज करके भी कंपेयर कर सकते हो. टू एक्सपेरिमेंटल डिजाइन कि जहाँ पे आप प्री टेस्ट पोस्ट टेस्ट दो ग्रुप्स लेके करोगे, एंड दैट कुड बी लाइक अ फैक्टोरियल डिजाइन कि जिसमें दो ट्रीटमेंट मॉडलिटीज कंपेयर होंगी. That is also a possibility. It depends कि आपको feasibility कौन से डिजाइन में ज्यादा मिल रहा है. और अगर आप कंपेरेटर लेकर करोगे ये डिजाइन तो ज्यादा इफेक्टिवली आप बोल पाओगे. इवन जैसे किसी पेशेंट ने अगर रिजेक्ट किया है ट्रीटमेंट एंड दे आर योर कंपेरेटर्स, तो आप बोल सकते हो कि जिन्होंने रिजेक्ट किया है उनसे अच्छा हम इफेक्ट इसमें दे सकते हैं.
Yes, yes.
तो ये बताने के लिए तो आपको कम से कम कंपेयर चाहिए. So
yes, so we can add that control group. We can add that. No problem.
So ideal way would be with the control.
Yes.
Second option will be with the alternate treatment modality.
Okay.
और अगर दोनों भी पॉसिबल नहीं है तो प्री टेस्ट पोस्ट टेस्ट सिंगल ग्रुप, वो तो मतलब वो तो ऑप्शन है ही आपके पास ऑलरेडी.
Yes, yes, yes. So that is the factorial, ना मैम. कॉस्ट
जो दो ट्रीटमेंट का है उसको फैक्टोरियल बोलते हैं.
हाँ, दो ट्रीटमेंट का फैक्टोरियल.
राइट.
Okay.
Any other queries?
No, ma'am. Thank you. Thank you.
Okay. Thank you.
Last group is remaining.
Okay, so I need a joining link for that. Okay. Which you want to talk to, or you can develop one new model and you can discuss that.
Yeah, Pritesh, go ahead.
Hello.
Yes, sir.
Can I start?
Yeah.
Start.
Researchers would measure the attitudes of students at a particular school during 1 week, implement the anti-drug program during the next week, and measure the attitude again following week.
Okay.
Pre and post design.
Okay, pre and post design, and no comparator as such, just single
Yes, ma'am.
pre-post.
Yes, ma'am.
Okay, so why you are not considering comparator here?
I mean, just a pre and post design, that's why.
Okay.
Madam, it's an unpaired group probably. Means same group. Before.
Yeah, same group is there, but when you are undertaking this training or a counseling program, it can be done for the other group of students also. So,
means
not
then
considering that. See, the same program can be considered in the true experimental setup, where one group could be those who
50 guest lectures, and his topics of expertise are systematic reviews and meta-analysis, research methodology, and biostatics. We are glad to have you, sir. Over to you now. Thank you.
Thank you so much. Thank you for your kind introduction. Thank you, Karibasappa sir, for inviting me.
Yes,
thank you, Principal sir, for considering me for this workshop, and thank you so much for inviting me for the same. And okay, let's start with the topic, and let's make it a little quick. Okay. Is my slide visible, sir?
Yeah, visible.
Okay, sir. Okay. Okay, good afternoon, everyone. And I hope you had a wonderful session till now. All the sessions conducted in the research methodology workshop was really interesting, and I hope you got some knowledge regarding the same. Now, I want everybody to be interactive during the whole session. I don't want, one-on-one. I'm not here to teach you. We are going to have a little discussion over here. So let's start with it. Now, everybody knows. Can you find the mistake in this particular slide? Can anybody put up in the chat box or unmute yourself and tell me the mistake in this slide? Or can you find the mistake? Kindly put up in the chat box, or you can unmute yourself and say to me. You can unmute yourself. I'll not be able to see the chat.
The.
Okay, very good. Anything else? Okay, the whole concept is how you present your data. The topic which I'm going to present is the data. If I put mistake, highlighting mistake, then everybody will look into the mistake word. Or if I put some colorful numbers, then they will start looking at the colorful numbers. Actually, the problem was there is two the. So the whole concept is I'm going to take up is the data and the data presentation. My name is Dr. Vinit Vinay, and everybody knows about the data. So let's not waste much of time because I'm going to lose data of my internet. So you know what is data? Data is about, the storage, in the floppy disk, in a pen drive, or everywhere is data. Even your network, internet network, like Jio, Airtel, Vodafone, even your Facebook data, WhatsApp data. So in life, there is so much of data. And it's important to understand this data. Then you have to see what type of data it is and how do you present your data. So data is not only numerical numbers. Data means anything. Your gossip is a data. So that's day-to-day of life. You have gossip. Social distancing is necessary, but gossip is important. So gossip itself, the content of that gossip itself is a data. And in articles, when you go through the articles, you will see a lot of data in there. So data is present each and every place. And when you are a postgraduate or when you were a postgraduate, your supervisor or your guide used to tell, I want data now. So every work you do, be it dentistry, be it medical, or be it any field in your job, they will ask you to progress report, the data. So love them or hate them, data is everywhere and you cannot ignore them. So if you're going for your thesis, the most important part, actually all the parts are important, but your thesis is not fulfilled unless you have a data. So there will be a time where you're going for collection of data, or when you're in your clinics, you're collecting data. So data is very, very, very important. What is data? It's a collective recording of observations. So whatever you observe, you record, it's called as data. So it is an individual pieces of factual information recorded and used for analysis. That is important. So this is where when you collect the data and then go to a statistician or you do it by yourself, you analyze those data. So data is nothing but a raw information from which statistics is created. And statistics are the results of data analysis. So when you analyze the data, you come out with the statistics, with the result. And then you interpret and present. So that is the whole concept of data. Now, for an example, in our day-to-day life, or in Hollywood, or in Bollywood, everywhere, Are o Samba kitne aadmi the? So kitne is a number, you know, and then hum ek baar jeete hain, ek baar marte hain, blah, blah, blah. So that is a number. Ek is a number. It's a data. एक लड़की को देखा तो ऐसा लगा is a data. ये 2.5 किलो का हाथ itself is a data. 2.5 किलो. And डॉन का इंतजार तो 11 मुल्कों की पुलिस कर रही है. 11 is a data. 11 is a data. And आप पुरुष ही नहीं महापुरुष हैं. So that is a data that is called as qualitative data. Purush and Mahapurush is a qualitative data. So there are various types of data. So data can be of different qualitative, quantitative, primary, secondary. All these are various types of data. So let's talk about different types of data. So we have observational data, experimental data, simulation data, and derived data. Observational data means when you observe certain behavior or activity, that is the observational data. So when you look into a patient's mouth and you see the number of caries, that is observational data. Then you have means like for example in the movie Parmanu, they observe from the satellite, right? They observe from they observe the Earth or any activity through the satellite. That's an observational data. So observational can be of two types. It can be a structured observational data or unstructured observational data. Structured means looking for something. You know what exactly you are looking for. Unstructured means you are looking at something, but you don't know exactly what you're looking at, but you're collecting a lot of information from there. And later you will structure it. That is called as unstructured data. So observational data can have certain advantages as well as disadvantages. So data that provides direct information is an advantage. It is unobstructive. Its advantage, it's flexible and discovery oriented. Disadvantage is it is time consuming and it requires diligence and preparation. That is important. So these are the disadvantages of observational data. Coming to experimental data means when you do an experiment like randomized control trial or an experimental study, you do an experiment, you do an intervention, and then you check the values, what changes are there. That is called as experimental data. So for an example, in the movie Chris, so all the characters were out of an experiment. So in this experimental data typically allows the researcher to determine a causal relationship. In the previous lecture, I think ma'am would have told you about the relationship. So when you do an experimental study, you understand the causal relationship. And when you do an experimental study, you come out with experimental data. Then comes simulation data. Simulation data means imitation, it generated, this data is generated when there is a imitating the operation of a real world. For an example, when you go for a car driving, when you go to learn car driving, in certain like Maruti and all, they will not give you the complete car at once. They will ask you to try in a simulated car. So you have to sit there, you have to change the gear, accelerator, and all those things. So there you get simulation data. In a real situation, what happens? You imitate that and generate the data. That is called as simulation data. Like for an example, if you have a typhoidont or if you have some, three-dimensional surgical simulation when you do on dummies, that kind of data is called as simulation data. For an example, in the movie Ravan, now the characters are game-based. They simulated and then they observe the data. So that becomes a simulated data. Then comes the derived or compiled data. Now what happens is existing data points, from different sources, you create a new data. Somebody else has done a study, in somewhere else. And from that study, you're taking some kind, deriving the data from that. That is called as derived data or a compiled data. Okay. So these are the 4 different types of a study. For an example, compile data, in the movie Sachin, The Billion Dreams, they from here and there, they took some bits and pieces of his life and they collected together and formed a movie or a documentary that is called as derived or compiled data. Coming to another type of data, it is called as primary data and secondary data. Simple. Primary data means anything which is done directly on the patients, like interview or examination or questionnaire. But secondary means any data which can be obtained or which is obtained from previous records or census data. Census means the data by the government of India. They conduct census every 10 years. And from that data, if you take, from that records, if you take the data, that is called as secondary data. So primary data is a fresh, first time data. Any study which you do, your thesis, you should do a primary research, collect primary data for your thesis. So that becomes a primary data collected from the field under the control and supervision of the investigator. It means original data. So that is primary data. So there are various sources of primary data. For quantitative data, quantitative means quantity, like if you're talking about or mg or anything like blood glucose level or bone height, and all this becomes a quantitative data. Qualitative data means if you want to know somebody's opinion about something or their belief or their attitude, so all this will become a qualitative data. So sources of primary data, quantitative data are experiments, mechanical observation and simulation, and surveys. For qualitative data, it can be a focus group or individual depth interviews or human observation or case studies. So that becomes a qualitative data. Secondary data means some data gathered and recorded by someone else prior to you. So that is called as secondary data. So it involves less cost, time, and effort because somebody else has done the study and you are just taking a data from them. That is called as secondary data. Okay. Now there are various sources of secondary data. It can be from any, patronage results or marketing activities or cost information or customer feedback. Or you can get some published data from government or trade associations, periodicals, newspaper, books, reports, private studies, or it can be from standardized source of marketing like audits and all those things. So these are the different sources of secondary data. For an example, Ghazi Attack was a movie, okay, which came first, and from there it came the movie Razi. So Razi was a prequel of Ghazi Attack. Okay, actually Razi happened first and then Ghazi Attack. So that was a secondary data. Now data can also be qualitative. I told you already, qualitative data or quantitative data. Qualitative means anything you are talking about quality of something. For an example, if you are talking about quality of a gingivitis, mild, moderate, severe, or malocclusion, class 1, class 2, class 3, that becomes a qualitative data. But if you are talking about the missing teeth, number of missing teeth, or crown length, then it becomes a quantitative data. So whenever you do a qualitative data, you have to go with frequency. That is called as frequency data or frequency analysis. Whenever you do a quantitative data, you have to go with descriptive analysis because the data are discrete or continuous. I will tell you what do we mean by discrete and continuous. So let's see this picture. The qualitative observation of this picture is a bunch of beautiful round and smooth glass marbles. Quantitative means 5 marbles of 1.5 centimeter diameter each. So this is qualitative we are talking about and quantitative. Am I clear, everybody? Anybody has any doubt can interrupt me and ask.
Go ahead.
Thank you, sir. Now, again, I told you data are qualitative or quantitative. Qualitative means attribute data or open data. Attribute means something like male, gender, or female, or something like that, or religion. Quantitative means discrete data or continuous data. Discrete means which has only limited options. They are not in a continuous scale. For an example, yes or no, boy or girl, like that. Some ordinal means something which is in order, like mild, moderate, severe. And binary means which has two options, yes or no, good or bad. Continuous data means something which is continuous, which has a scale, which is continuous. There is no limit. It can be anything. It can be, the value can be 2, or the value can be 2.5, or 2.35, or 2.4901. Any value can be there. That is called as continuous data. Okay, so qualitative data is, talking about quality. Whenever we talk about quality, in this picture, the qualitative data of this picture, oil painting, is blue and green color, gold frame, smells old and musty, brush strokes of oil paint, peaceful scene of a country, and masterful brush strokes. But when you are talking about quantitative data of the painting, it means the picture is 10 by 14, 14 by 18 with frame, 8.5 pounds and 140 square inch, and the cost is $300. So that is quantitative. So can anybody tell me what is ab tak 56 qualitative or a quantitative data? Can you unmute yourself and say it's a qualitative or quantitative?
Quantitative data.
Huh?
Quantitative.
Okay. Can it be a qualitative also?
Yes.
It tells the quality of a person. He was an encounter
How
specialist, right?
How much
Very
data?
good. Can you yes? Can you tell me qualitative or quantitative? Rocky answer.
Qualitative.
Qualitative.
Qualitative. Okay. Can you tell me qualitative or quantitative?
Qualitative. Both.
Both. Very good. Okay, let's talk about discrete numerical data. Discrete means anything which has a whole number. So if I tell about 1, 2, 3, that is called as discrete. So if I tell there are 2 boys, it means it's a discrete number. I cannot say there are 2.35 boys. Can I say this? Can I say this, yes or no?
No.
Good. So there are 3 cones. Can I say there are 2.95 cones? No. So that is called as discrete data. But if I say the grams is 79.4 grams at 8.3 degree Fahrenheit, it is called as continuous data. So whole number means which does not have a decimal, which are distinct and separate, like number of people, number of kittens. Continuous means which has decimal. There can be a decimal number. They are not separate, but in a continuous range. For an example, height of a participant or height of a population. So height can be anything. It can be 6.1, it can be 6.2, it can be 6.3, it can be 5.8. So it is a continuous data. Okay. So that's a difference between discrete and continuous data. So 102, not 5. Continuous or a discrete data?
Discrete.
How discrete? 102 is a continuous number, age, right?
Yes.
Okay. Half girlfriend, discrete or continuous?
Continuous.
Can it be a half girlfriend? Okay. Now coming to scales of data measurement, we have categorical data and non-categorical data. Remember this NOIR, N-O-I-R, NOIR. Categorical means the data can be either in a nominal scale or an ordinal scale. So if I am telling yes and no, so will it be a nominal scale or ordinal scale? Nominal means anything which has name, boy and girl. Is it a nominal scale or ordinal scale? So categorical data can be nominal data or ordinal data. So categorical means I am a bird, yellow and awesome. I am a seahorse, orange and super awesome. And I am a T-Rex, green and extinct. So these are the categories. So there is anything which has a category is a categorical data. So nominal means when you have only names or tags, it is called as nominal scale. For an example, sex, it can be male or female or others, right? So it becomes a nominal scale. Boy or a girl, it becomes a nominal scale. Religion means Hindu, Muslim, Sikh, Isai. So that becomes a nominal scale. Anything which does not have a magnitude. Okay, only names or tags. Binary means anything which is dichotomous. Anything yes or no, present or absent, male or female. Any option which is dichotomous is called as binary scale. Ordinal means anything which is in order. It is like nominal, but it is graded. There is an order: mild, moderate, severe, poor, satisfactory, good, excellent. Your Wong-Baker faces pain rating scale is an order, ordinal scale. Am I clear, everybody? Anybody has any doubt till now? Thank you, sir. Interval means anything which does not has a true 0 point. Have you ever heard of 0 degree Fahrenheit? कभी सुना आपने 0 degree Fahrenheit? Anybody? No, have you heard of 0 degree Celsius?
No, sir.
You will hear 0 degree Celsius, but you will never hear 0 degree Fahrenheit. So Fahrenheit, measurement of body temperature in Fahrenheit, is a interval scale. Getting my point? There is no true 0 Fahrenheit, the true 0. Ratio means which starts with 0. There is a beginning at a 0. So 0 degrees Celsius, it starts with, or the weight, the base of the weight will, every time we'll calculate the weight from 0 only. But there cannot be a negative measurement. Minus 40 kg कोई नहीं होता है. या minus 5 meters, 5 feet कोई नहीं होगा. There is no negative measurement. That is called as a ratio scale. Any scale which does not have a negative measurement is a ratio scale. So we have a nominal scale, ordinal scale, interval scale, and ratio scale. Okay. So these two, interval and ratio scale, are a continuous data. Nominal and ordinal scale are discrete data or discrete scale. So why it is important to understand data? So that you get a summary measure. What is a summary measure? Mean and standard deviation, basically. And proportions. So Unless and until you have a data, you will not be able to analyze that data. You will not come out with a statistics. And if the data, you have to check whether the data is normally distributed or not normally distributed. On the basis of this, you can apply parametric or non-parametric tests. So the method of data present, let's go to data presentation method. Remember, when you have a qualitative data, go with tables, more of tables or pie charts or bar graphs. When you have quantitative data, go with box plot, histogram, XY scattered or line graph. So dental age estimation. Can anybody unmute yourself and say me, dental age is what type of data? Is it a discrete data or a continuous data?
Continuous.
Continuous, very good. Is it a qualitative data or a quantitative data?
Quantitative data.
Perfect. Thank you so much, sir. Let's talk about mouth opening in a patient with oral submucous fibrosis. We are looking at the mouth opening. Is it a qualitative?
Quantitative.
Quantitative.
Very good. It's a discrete or continuous?
Continuous.
Continuous.
Very good. But if I say mouth opening is low or high, then what type of data it will become? It will become a qualitative data.
Ordinal.
And it will become a discrete data. Or it will become an ordinal data if you have orders. Right? Now, bone regeneration and flap surgery. What type of data will it be?
Qualitative.
And if I measure the bone height?
Quantitative.
Perfect. Perfectly fine. Sabko pata hai, I am simply taking it. Okay. What type of data is this? It's that calming down, and yoga is helpful for that. Stress reduction is a big one. After yoga, I feel more relaxed. Which data?
Qualitative.
Data.
Perfectly fine. And the type of study is called as qualitative research, which I will be taking tomorrow. Right? Rigid internal fixation of zygoma fractures using 2-point and 3-point fixation.
Quantitative.
Okay, good. Conventional pro-taper hand and pro-taper rotary instrumentation system.
Quantitative.
I want to see how much is a dentine cutting, you know, how much they're cutting the dentine.
Specific. Continuous.
Continuous and qualitative. Quantitative, right? I want to see the thickness, dentine thickness after rotary instrumentation. That becomes a quantitative, continuous. Assessment of child's dental anxiety in 5-point scale. Qualitative, perfect. And then what other type?
Ordinal.
Very good. Discrete or continuous? Discrete, right? Because discrete has ordinal and nominal. So when you are taking ordinal, it means it is discrete. Perfectly fine. Sealing ability of a root canal sealer. Okay, ability. But if I'm measuring it, it becomes quantitative. Perfectly fine. And this dental fear and anxiety in children and adolescents. Perfectly fine. Awesome. Antibacterial activity essential oils on respiratory tract pathogens. Antibacterial, so reduction of coliforming units. It is
Quantitative.
I'm talking about CFU.
Coliforming units.
Coliforming units, there is a reduction.
Quantitative.
10 to the power 6. So quantitative. So statistical analysis method and technique are very important. When you're talking about descriptive statistics, you will talk about tables and graphs and summary measures. When you're talking about inferential statistics, you'll be talking about confidence interval and hypothesis testing. Okay, coming to presentation of data. So data can be of two, variable type or a frequency type. This is the element of classification. And data presentation can be done in text format, tabulation, or graphical format. So when you're talking about text format, it means when you're writing the results in theory, in paragraphs or sentences. For an example, the incidence rate of delirium following anesthesia was 11% in 2016 and 15% in 2017. No significant difference of incidence rate was found between the 2 years. That is called as textual type of data presentation in a form of a text. Tabulation means when you are forming tables. It's called as tabulation. For an example, something like this. When you're presenting your data in a form of a table, it is called as table type of data presentation. So remember, in this, there is a table heading on the top. Then there is a box head. This blue box is called as box head. Then you have stubs. Small boxes are called as stubs. And this is the whole body of your table. And you have a footnote here. One second, I just missed it. Is my screen visible? Is my screen visible?
Yes.
Yes, sir.
Okay, fine. Coming to tabulation, there are different types of table: simple table, master table, or frequency distribution table. This is a simple table where you have, for an example, I want to see average caries experience in 6 districts of Maharashtra: Pune, Mumbai, Satara, Bid, Nashik, Nagpur. This is a simple table. One side you have a DMFT region, one side is the average DMFT. Master table means when you have a different variables in one table itself. You have an age, you have a sex, you have education, decade, missing field in one table itself. You are supposed to make master table in your thesis, something like this. And then you have a frequency distribution table in which there is an interval. So 1 to 3, how many are there? 4 to 6, how many are there? 7 to 9, how many are there? That is called as interval or frequency distribution table. Coming to graph and diagrams. Why graphs and diagrams important? Because it impacts on imagination, better retained in memory, and for easy comparison. So there are various types of graphs presenting quantitative. When you are doing a quantitative research where your data is quantitative, continuous, or measured data is through graphs, histogram, frequency polygon, frequency curve, line charts or graph, cumulative frequency diagram, and scattered or dot diagram. When the data is qualitative, discrete, or counted data, then you should go with bar diagram, pie diagram, pictogram, and spot map. I'll show you how these diagrams look like. This is called a simple bar diagram. You have 4 bars here, simple. You have mean number of missing teeth and which age group. This is called a simple bar diagram. Multiple bar diagram, now you have 2 bars at one age group. You have male and gender, female there. So that is a multiple bar diagram. Then you have a component bar diagram. Component means in one bar itself, you can have number of observation. For an example, for endodontics, for pedodontics and periodontics, in January, how much was the number of patients? So in one bar itself, you will have different components. So January, April, September, like that. So that is called as component bar diagram. Proportion percentage bar diagram means you will, in the diagram, the maximum unit will be from 100 till 100%. So all this component part will include within 100. For an example, from 0 to 40, this is 40%. Then from here to 20%, and this becomes again 40%. So oats, barley, and wheat. So within 100%, you have to make that bar. So that is called as proportion or percentage bar diagram. Then there is something called as deviation bar. In the diagram itself, you can understand how much is it deviating. So for an example, there is a decrease, there is an increase, decrease, increase. How much is it deviating from the center point? That is called as deviation bar diagram, which can display both positive and negative changes as well. For an example, in this also, from the center, how much the female income, how much is the male income. So within one diagram, you can understand what is a change. So that is called as deviation bar chart. Histogram. Now, like simple bar diagram, I told you how the simple bar diagram looked like. It looked like something like this, right? So there was value 3, 4, 5. So you can see there is a gap between two bars. So this is a simple bar graph. But in histogram, there is no gap between the two bars. Because in histogram is usually for interval. So 8 to 9, how many are there? 9 to 10, how many are there? There is no gap between 9, right? So it's in continuity. So that is called as histogram. Don't confuse histogram with bar diagram. Bar diagram, there will be a difference. There will be a gap here between the bars. In histogram, there is no gap between the bars. Now, if you take a midpoint of all the bars and you connect them, that is called as frequency polygon. I hope you got my point. Histogram, if you connect the center point of the bar and connect them, that becomes frequency polygon. For an example, in this exam scores, you start with here, something like that. This also becomes same, almost same. So this is histogram and the line chart. This is a line diagram. Number of patients visiting OPD. It is a line diagram. Line graph you would have seen in cricket, Australia and India. So what is the score? What is the run rate per over? So that is called as line graph. Scattered or plot diagram is for correlation. Whenever you're planning to do a correlation, you will go with a scatter plot. So I want to correlate between the degree of fluorosis and fluoride level in water. That is called as, we have to draw a scatter or a plot diagram. So whenever you are going with a correlation in your study, ask your statistician to make a scatter or a plot diagram. Pie diagram. I told you for qualitative data, you will go with a pie diagram. So in this, I want to see how many, what is the distribution of type of malocclusion among 15-year-old school children. So I've divided into a pie. So the whole pie will be of 100%, of which 65% are class 1, 15% class 2, class 3, and class 4. Map chart. There are some diagrams like map you have to make. So incidence of fluorosis in different states of India. So if it is a blue color, disease not detected. But if it is a purple color, less than 30% of district affected. There are 4 states in that. So that is how it is. Map chart. Then you have spot maps. You would have seen spot maps everywhere. So this is how the spot maps look like. And sometimes you have to draw pictograms. So pictograms means you will draw a picture. So if you are doing something for a mobile network, your picture will be of a mobile tower with signals. So one tower will depict 10%. So there are 3 towers. So how much it will be? One tower depicts 10%. There are 3 towers. So how much it becomes?
30%.
Very good. And there are 4 towers. So how many it becomes? 40%. So instead of making so many towers, one tower will represent 10%. So sometimes we can draw like this also, pictograms. For an example in this. So in one picture itself, you will understand the status of the oral cavity. Everything you will understand in a pictogram. Okay. So this is how you can draw pictogram. Like in this. So one person is depicted here. So 1, 2, 3, 4, 5, 10. Each is depicted as 10. So 1, 2, 3, 4, 5, 6, and 6.5. It becomes 65 men. Similarly, 45 women and 50 children. So this is called as pictogram. Box and whisker plot. You will generally see this in some studies where they are doing this, for an example, meta-analysis or something like that. There also you will see box and whisker plot, or some randomized control trials also you can draw box and whisker plot. So you have a mean value, the center value, mean plus standard deviation is the whole box, and minimum and maximum is the whisker. This is called as whisker, the T shape. So you can make box and whisker plot also in your studies. This is how box and whisker plot for different study randomized control trials we can draw. For shear bond strength values, you can draw box and whisker plot. So highest value will be there, lowest value will be there, median value will be there, and lower quartile and upper quartile will be there. So for us in this study, they have done a box and whisker plot. Then you have a forest plot, which you do in a meta-analysis. This is how it looks like, the forest plot, when we conduct a systematic review, and after systematic review, we go with the meta-analysis. This is what we draw, forest plot. And with this forest plot, we also have a funnel plot. You can see this funnel shaped plot. This is called as a funnel plot. So if it is symmetric, it means there is no publication bias. If it is asymmetric, it means there is a publication bias. And then you have a stem and leaf diagram. For an example, in this, you have a stem and then the number of leaves. So how many? 5 are there, 8 are there, 4 and 6 are there, and it increases. That is called a stem and leaf diagram. Population pyramid looks like this. The population in thousands for male and female. So it looks like a pyramid. So this is called as population pyramid. And decision tree. So when you make a diagram for decision tree, it looks like this. 1, if A, these are the outcomes. If it is B, then 2, these are the outcomes. Something like this. Something like this. You know, region are hard to explore and all those things. It is, you make a decision tree like this. And this is the decision tree again. So if you have periodontal cases, you know, apply grade modifier, upgrade diabetes or smoking, then no change in grade, upgrade to B, upgrade to C, and all those things. Again, a decision tree for tooth replacement decision. If you want to make, you can make a decision tree. Summary measures. After getting data, you have to do summary measures, which can be in a form of mode, median and mean, range, and standard deviation. So this will be covered in your statistics, I think. So we have to, you know, measure range, minimum, maximum, all those things can be done. And standard deviation you have to do. So we have standard deviation, how to calculate standard deviation. You will learn in your descriptive as well as inferential statistics. And data can be distributed, or you have to check how the data is distributed, spread out in a different way. So it should be in a normal bell curve. So normal distribution of data means the mean, median, mode lie at the same point, center point. And standard deviation means how much is your data varying from the central point. That is called as standard deviation. So why do we need standard deviation? Because your data is likely to be within 1 standard deviation, 2 standard deviation, and 3 standard deviation. And for this, you will do inferential statistics that is called P less than 0.05. That's all from my side. Do you have any questions or doubts? You can ask me right away. Thank you so much.
Thank you, Vineet.
Thank you so much, sir.
Yeah, tomorrow again we'll start at our scheduled time. You take rest, and really I'm very thankful, even though you're running with high temperature.
No problem, sir.
You came and given your expertise.
Sir, I have another data and data presentation lecture right now for JJ Hospital.
Now you take rest and go to JJ Hospital. Tomorrow you come back, but don't stress yourself. Okay?
Yes,
take
sir.
care.
Sure, sir. Yes, sir. Thank you so much, sir.
One second, wait. There is a question now. They don't want to leave you. Wait. Wait. One question
sir, what is the best data representative for comparative study?
Answer.
The best data representation for comparative study is a box and whisker plot. Whether it's a randomized control trial or anything, you can go with a box and whisker plot. But if you want to make it very simple, keep it bar diagram only.
Wait, one more question is there. Something Madam has asked. Just check. Something with parts of table.
Sir, please show the slide with parts of table. Okay, I'll come with the slide with parts of table.
Vineet, you take proper rest. Tomorrow, don't miss. Morning, you have to come. And
yes, sir. Don't worry. Sir, commitment is commitment, sir.
Yes, boss. Thank you very much.
The parts of table.
कुछ होता है करको गया तू.
This is a part of a table. So we have a table heading. Is it visible, sir? Is my screen visible?
Yes, Vineet, visible.
Okay. So this is a table heading. Then we have a box here, box head. Then the whole body and tubs. Tubs means the niche wala part, the gray part. So this is a table heading. This point is a whole heading. The table 11 is a whole heading. And then we have a box head, this light blue color, everything is a box head. Then we have stubs, the white section, the white part is a box stub, and the whole part is a body, including box head and stubs. And footnote is this p-value, which I have written here. The footnote is this p-value. Am I clear, ma'am?
Yes, sir. Thank you.
Thank you, ma'am.
Thank you, Vineet.
Thank you, sir.
We'll wind up today. Again, we'll meet tomorrow morning.
Sure, sir.
Yes, take care. Take rest. Morning.
Sure, okay, thank you, sir. Thank you very much.
Bye.